we
This
shift the time.
conference will
Okay?
now be recorded.
If they agree, then we can, of course, we can do that. Okay, because I will bring the MRCPI people early and shift you guys later. So here is your first case for the emergencies. So in the emergency, there are certain things. Okay,
Mm-hmm.
always say very clearly this is an obstetric emergency or this is a gynecologic emergency. I
Mm-hmm.
will call for help. I will pay attention to the initial assessment of the patient, do the initial assessment, resuscitation. After that, you will start reviewing the charts, okay? What has been done so far and what we are going to do
Mm-hmm.
afterwards. Then appoint one person. That's very important. I will appoint one person to take notes with timeline. They should know that what was done, who joined us, at what time, in what sequence, and what they did. This is very important for the ongoing and subsequent management of the patient, so that we will not be giving any drug by fault by twice, or we will not be missing any important part of the management. I will initiate Neo's charts. Okay. If it is the OB-GYN case, you will initiate MEOW, Modified Early Obstetric Warning Scoring System. If it is gynae case, then you will start MEOS, that is Modified Early Scoring System, MEWS. Okay. So in the how you will sometimes the examiners they can be funny. They can ask you how you will interpret that. You will say that if all the chart can have different colors, but one thing would be common that they all will have one yellow and one pink, or one yellow and one orange line like that. Okay, one orange red. You must have seen the charts many times. If any warning signs are there, like the observations are falling in the yellow line, these are the alert lines, just like the road traffic. Okay, one yellow line, you are going to assess that patient within 30 minutes. Two yellow lines, you are going to see that patient within 15 minutes. One red line, the patient should be seen by the senior within 15 minutes of the call. Okay, that's how you are going to read the MEOS chart. So you will score that chart, and then everything you are doing, you are writing that down. Okay. Always call for help. Always say clearly what is going on, what has been done, and what we are going to do now. Initial management, review the charts, appoint your staff, then continue with the ongoing management. Once the emergency is over, again you need to say, now this emergency is over. Okay, like even when there is code blue, what do they say at the end of the session like that?
Mm.
Code
Uh,
blue,
could you
close
say
now,
more
the
say like
situation is over. Okay.
uh,
And when you need to involve the critical care team, you should involve them. Like the patient is collapsing, you will inform the critical care team as well. In each hospital there are critical care teams. I was also a member of the critical care team. So if anything anywhere goes wrong, you will get your bleeper, you will get a bleep, and you have to go and attend to that one. Okay. So after that, you will say, I will say, once the patient is safe, things has been done, then I will sit and I will write clearly that I was called for this patient at this time, and then I was busy with resuscitating efforts. And now, after finishing the case, I am writing my notes with the help of the documentation that my staff has done. You have done everything, write down everything, even the tiniest things. If you have done any surgery, write down what you did, what was the extent, what did you see, refer to my OR notes, all of these things. Okay, so you are not supposed to write that I will suture this, I will suture the stuff with this, and I will then give her suppository like this. Just say that refer to the operation notes, because you are not going to write the same thing again and again. They will have to look at the OR notes. Then very important that next day on the rounds, I will like to debrief the patient, because emergencies, they can be like life threatening, they can just be so scary. and the patient can go into PTSD. In almost all of the things, the patient is going to have some degree of depression and anxiety, and God forbid, they can develop full-fledged postpartum depression, which is 15%, or post-traumatic stress disorder. Some of them, they can develop acute stress disorder, which will last only 3 weeks. But once you say PTSD, then it is going to last longer than 3 weeks. That is one thing. If she is under tremendous pressure and she needs, your assessment is that she will benefit from the psychotherapy. Sometimes, the patients, they will become suicidal. So after losing, especially after losing the baby, okay, they will not eat anything. They will just be having recurrent thoughts of killing themselves, that they have failed themselves, they have failed their families. So very important to say that what has happened, this is a recognized emergency. It does happen, and nobody could have done anything here, not your fault. But luckily, we had a way to address it, and we can move forward. Now, your baby will have this, you will have this 1, 2, 3.5, and that's it. Then risk management is becoming increasingly important. You have been talking about the risk management before also, but we will say here regarding risk management, we will arrange skill drills. We will ensure that everyone on the floor knows what to do if such an emergency arises. In most of the skill drills, the drills are done once a year. Okay. If they give you someone that the patient is complaining that the doctor XYZ didn't manage me properly and the things have taken place, then you will say, I cannot comment on it outrightly. I need to have a look at the notes. After going through your file, we will recommend that a risk assessment committee RAC should be made. There will be several members on the team, like the consultants, specialists, and the other specialties, and the people who are impartial. Like they were not directly involved in your patient care, they will take statements of everyone whosoever has come across you during your stay in the hospital, right from the time of admission to the time of discharge. Okay, then we will plot everything on the chart, and then we will see that where the staff is, where are there was some defect in the care. They ask you that which analysis you can use. The easiest one would be fishbone analysis. Okay, what is fishbone analysis? One straight line is going. Who came? What we did? Where was the fault? Was the fault with the person, with the machine, with the equipment? The things were not available, that is in the machine, with the drugs. Okay, or it was there was a problem in handing over anywhere. Where was the defect and what time the defect occurred? So they are going to pinpoint it. Then they will give you the a final report, and then in the light of report, you are free to launch a complaint, or if you want us to do something else, we'll be doing that. Okay. I will invite questions and I will like to address them with evidence like that. Okay. Another thing of the risk management would be we will regularly update our protocols in the light of new emerging medical evidence. So we will do that, and then we will keep functional protocols. MOH has wonderful protocols, but some hospitals, they follow them very seriously, and some places I have seen people are not like very much strict about the protocols. Remember that protocols are not to punish anyone; they are to keep everyone safe like that. Okay, that is one thing. So that's all you need to do. Still, your patient wants to complain. I will tell her about the complaints committee. So and guide her to go there and do the needful. That's all you need to do. Okay. Debriefing would be very important. Clinical governance would be very important, and the risk management. All of these things are important. Even if they don't ask you, just say one line. Regarding clinical governance, I will recommend this. Regarding risk management, I will do that. Regarding debriefing, I need to do that. Debriefing, don't forget that is weighed very heavily in your OSCE, because you need to tell the patient what exactly has happened, because everyone has not been to the med school, right? Sometimes you will get the people who are coming, like for us, they used to come from Bahama, from many other places where they had no exposure to such things. So you have to go to their level and you have to explain everything. This is your ethical duty. This is your professional duty. Okay. So that is the thing. So let's start with Fatma. I think she came first. So let's Fatma, go with this one. Uh,
Uh,
and today we have to do some emergencies and some we have to do the like we can do the the some stitches from the maternal-fetal medicine as well. Okay. So first try to finish this one, then we will go to that one.
okay.
Okay, your time starts now.
Discuss and justify your management. Okay, so this patient has shoulder dystocia, so I'll go immediately for her and I will introduce myself for her. I will call for help. I will call a neonatologist, anesthesia, nurses, and I will inform my senior registrar and consultant. Um, I will attend the delivery and I will tell her to stop pushing. Then I will request from my nurses to flex both hips, and I will be sure that all her she is vitally stable and she had good hydration. If she is not, I will put two large bore IV cannula, one for investigation and the other for IV fluid. I will request type and screening, press match, 2 units, 2 to 4 units of blood. Um, uh, I will request from the patient to stop pushing, and I'll flex both her hips. I will check the presentation. I will go for this. Let me call it. I forgot the maneuver. What was the name of maneuver? I forgot the name of this maneuver, hyperflexion of
Okay.
hip and
You know, you don't
yeah,
have to say the names of the maneuvers, okay? You will
yeah.
just describe that what you would like to do.
Okay. First, I will do this maneuver. If it's failed, I will request from one of the nurses to make a pressure in the symphysis pubis as well. Then, if it's not coming, I will try to deliver the anterior arm. Uh, if it's not, I will do wood corkscrew maneuver to make the diameter uh, the diameter shorter. Uh, if it's not come, uh, if it's not come, I will do ropen maneuver.
Mm-hmm.
Uh, if it's not done, if it's still failed, either I will break one of the clavicles and I'll try to deliver the baby, or symphystomy, or last option, Zavanelli. Zavanelli, then I will do CS for her. Um, uh,
Okay,
okay.
that's fine. So, what complications the baby can have as a result of these maneuvers?
He can have like brachial plexus injury. He could have he could have uh, birth asphyxia, intracranial hemorrhage, intraventricular hemorrhage, low Apgar score, cerebral
Yeah.
palsy.
Brachial
Uh,
plexus injury, soft tissue injury, like you said yesterday,
mm,
right?
yes.
Even in the
Uh,
breech, just like breech, we are going to pull at the shoulder and the head. So
yeah.
11th nerve injury can be there, but most commonly there will be shoulder dystocia like that. Okay. So what
Yes.
problems the mom can have?
Okay. The patient could have maternal risk. She could have dehydration, cardiovascular collapse. She could have birth perineal trauma, third, fourth degree perineal trauma. Um, uh, she could have an instrumental delivery, and she could have CS and the complication of CS like vascular injury, visceral injury, extension of the wound, VTE.
Yeah, you can
Yeah,
say that to begin with the simplest thing, two things are established.
yeah.
Third and fourth degree perineal tears, the incidence is 3.8%, okay? And the PPH is the biggest risk, okay? PPH, the incidence would be 11%. It's very high.
Mhm.
Then she can have a ruptured bladder, okay? And she can have vascular injury, okay? And then rest of the things you are showing, saying extreme fatigue, extreme stress, dehydration, okay? And then what else? She is at risk of developing like we said before, PTSD. Okay, but so and for the baby, you can say that fractures of the humerus, that is long bones, 12% incidence. 12% is again very high. Okay, and clavicular fracture, so we can do clidotomy, but even without that, they can have a fracture. Okay, brachial plexus injury is very common, and in all cases of the emergencies, your baby is going to have hypoxia. Due to hypoxia, the baby can develop hypoxic ischemic encephalopathy. Okay, and death. Risk of death is also there. That's very low, but still the risk is there. Okay, so in each emergency, you are going to fit in this thing. That is the point. Okay, so for this woman, the baby had low APGAR scores, and baby has like some this lower injury into the um, lower part of the lower trunk of the brachial plexus. Okay, so baby is getting physiotherapy. So the
Mhm.
woman has come to you. She had extended episiotomy, but luckily no third or fourth degree perineal tears. So
Mhm.
what will you like to tell her?
Uh, First of all, regarding whatever happened, I have notified the risk management team for this case, and I check where was the problem. If it was like patient factor, she was not following up. She was not have a proper antenatal care. If it was hospital factor, there was a lack of protocol, consent, equipment, uh, uh, the physician factor, the training level, the supervision, uh, teamwork, communication. Um, I will do incident report, and I will make sure that I will notify the patient that I will we escalate incident report for incident report for whatever happened, uh, and and I will document everything in details, and
Mm-hmm.
I will, yes. And regarding how would you contact the patient? Regarding subsequent pregnancies, I will counsel her to do like early antenatal follow up, and to check if she has any chronic medical illness like diabetes, to have good control for her blood sugar, and to do a proper ultrasound and anomaly scan, and to have a good plan for mode of delivery next time.
Yeah. And then you should, what is the risk of recurrence in such circumstances?
Um, I'm not sure about what was the percentage.
Okay, 1 in 16 to 1 in 25. Okay, you just write down all of you. So tell
120.
her that, yeah, uh, and you, I will like to look at the risk factor. So she's at 6 weeks postnatal review. Check her plasma glucose level, fasting plasma glucose level. Okay, at 6 weeks postnatal review, this is ACOG. If she is not fasting at this time, you couldn't do that. Then at 13 weeks, you will check glycated hemoglobin level. Okay, that is one thing. So then, if she is obese, we need to tell her about healthy eating and reducing her weight so that because maybe the baby was macrosomic, this is 4,600. So either mom has occult diabetes or she had this hyperinsulin, hyperglycemic environment. That's why the baby has grown that way like that. Okay. So the weight over like 4,500 in diabetics, we have to go for the section. Non-diabetic, 500,000 grams, then you have to go for the section like that. Okay, that is one thing. So early booking, and if the baby will remain symptomatic, then we will have to do something for it like that. So then another thing is that how you will manage the baby. So for the baby, you don't have to do much. If the baby has only this some problem in the bone clavicle or the muscles are torn like that, they don't have to do anything. They will simply just take the sleeve of the baby and pin it up with the safety pin to the chest of the baby like that. So baby will keep moving the arm a little bit, and this is like physiotherapy, and they're going to be fine. But if the pediatrician says that they have brachial plexus injury, even then 90% of the injuries they would resolve by simple physiotherapy, and 10% they are going to be residual. And maybe in such then in such children, sometimes they are doing surgery, sometimes they are doing like they are staying like that, and that is lifelong. But that is like a remote possibility like that. Okay, if the patient asks you that why you didn't tell us that beforehand that it will happen, then you can say that shoulder dystocia is something that nobody can ever predict, and even it can occur with the small babies, like the weighing less than 2 point, weighing up to 2,500 grams like that. Okay, good documentation is very important, and the documentation we are doing on a printed pro forma. And the cord blood samples, you will take double sample. Okay, or emergencies, the baby will have hypoxia, and you need to do the double cord blood sampling. That is one thing. Well done, Fatma. That's great. Okay, so this one also for you, Fatma.
Uh,
You
yes.
all will get equal number of cases. Okay, so don't worry about it.
Okay. Uh, Heart pattern has collapsed. You arrive in the room and the midwife is there with uterus inverted and placenta attached. The examiner will ask you a series of 4 questions about the management of this patient. What will be your immediate management action in being faced with this case? Okay.
If some of you, one of you is doing the station, others should also think about it. Okay, and then listen to the one who is presenting that if she or he has missed anything, and That is, you are also being assessed at the same time, okay? Don't do anything else at this time. Just focus attention because you know that only 20 days in hand, so we have to make the best use of it.
Okay. So, what will be your immediate management action in being faced this case?
Mm-hmm.
Okay, I'll go for this patient immediately, and I will check her vitals. I'll ensure that her airway, breathing, circulation is fine. Um, I'll put two large bore IV cannula, and um, I will order to stop oxytocin if it was already applied.
Mm-hmm.
Um, I will inform anesthesia and my senior. Okay, and I'll try to. I will ask anesthesia to give her Halithan, so I can try to invert her uterus to put it in its usual position, and I will be sure not to pull the cord. Um, okay. Uh, okay. If it's not inverted with me manually, uh, I will go for laparotomy and make certain procedures to adjust the uterine position, uh, which are, I think, Halban procedure. Uh, mm, and I will try to bring uh, two LS to adjust and adjust the uterine position by pulling the round ligaments. Uh, then afterward, um, I will, if I adjust it, I will give her oxytocin, and I will try to deliver the placenta. Uh,
Don't worry, this
okay.
is unusual situation, yeah. Don't worry, this is. So, what is your diagnosis? What exactly do we have here?
Uterine inversion.
Yeah, you're trying
Yeah.
inversion. So, is this an emergency?
Yes, it is.
Yes, it is because this is chronic. This is acute. Okay, so you know the uterine inversion. It can be chronic as well, like that. Okay.
Mm-hmm.
So, what will you like to do for her now after coming this far?
So now, what are the risk management issues are important here? Uh, Risk management. I will identify the problem, which was uterine inversion, and I will do analysis of the issue. What was the problem? What happened during delivery? Uh, was it like, for example, uh, uh,
Adherence. Mm-hmm.
adherent placenta accreta, or the resident was pulling the cord like earlier without waiting the sign of separation.
Yeah.
Uh, um, then I will check with the risk management team, the consultant, the senior registrar, the residents, anesthesia, uh, what, uh, and try to analyze the problems if it was like patient factor uh, or physician factor, lack of training, experience, supervision, um, uh, was hospital factor, the lack of protocol, consent, guidelines, equipment. Um, then then
Yeah, you're
I will
fine.
then I will disseminate this for the hospital administration and the national health. Uh,
Protocol guidelines.
yes. Then I will then I will document it and I will debrief it for the patient. Um, yes, and I will discuss how this can be prevented subsequently in the future, in general, for all the patients and for the patient.
Yeah, excellent. Well done. Uterine inversion is always challenging, but this is a way of indirectly asking you that your patient has PPH, okay? This is one of the rare causes of PPH because what is the incidence of having this uterine inversion? 1 in 2,000 to 1 in 6,000. So it is a rare condition like that, okay? That is one thing. So you will say that I will go and I will see the patient. That what is the status of the patient? Is she hemorrhaging? Is she oriented? Is she conscious? Because sometimes because of the pain and sometimes because of like heavy blood loss, the patient may be unconscious like that. Okay? Is the patient responsive? I will ask her. I will take her name and ask her, "Are you okay? Are you okay?" If she is fine, well and good. Otherwise, I will start the efforts for resuscitation to start with the oxygen. Oxygen is the first thing that you are going to give because even when you are putting two IV lines, you want to expand the blood volume. She is losing blood, you are expanding the volume so that the gaseous exchange will take place in the lungs and the patient would be getting some oxygen and it will prevent hypoxic or anoxic injury. So give her inhalation, okay? Improve circulation and give her oxygen 10 to 12, 10 to 15 liters oxygen per minute like that, okay? Call for help that patient has PPH. Still you don't know what is the cause like that, okay? After that what you will do, you will go and you will assess the patient, okay? You will call for help, tell the staff to put two IV lines and start crystalloids, okay? And then take vital signs, okay? They start this one. They will take the blood pressure, pulse, temperature is not required here. Continuous blood pressure monitoring, continuous SpO2, pulse oximetry, okay? That should be done continuously. Now I will go and I will do the inspection of the abdomen and then I will do the palpation. On palpation, what you will see, there will be a dimple, there will be a pit, a area will be empty while we expect that immediately after birth, the uterus should be palpable up to the level of the umbilicus. This thing would be missing in this case. Then I will inspect the vulval area and I will see that the placenta, that this is the placenta is attached and the uterus, what is the how much it has descended. There are degrees, but you don't have to say that this is the first degree, second degree, third degree, because then discussion will go to the other side. So then you will say that this is acute uterine inversion because if it is occurring immediately after birth, within 24 hours, you will say this is acute uterine inversion. After 24 hours, that will be subacute. And after several weeks, like after like 28 days, this will be like the chronic or late uterine inversion. Okay, so I will see that I will try to quantify the extent of hemorrhage. I will see that the placenta is attached. I will not remove the placenta. You have to say such things. I will not remove placenta because you will remove the placenta. In this case, she is going to have more hemorrhage. Important to say the positives and important to say the negatives. This is a case of acute uterine inversion. I will call for help. I will not remove placenta at this point. My aim would be immediate replacement of the uterus into the to its normal position, because you will just replace where you will replace it. Okay, my aim of my management would be to immediately replace it to the normal position. We can do it through several ways. The easiest one is placing a hand inside the vagina and pushing the fundus along the long axis of the vagina towards the umbilicus. Write down the name of this maneuver is Johnson maneuver. Remember it like this. You will make a fist with the left hand and keep one hand on the abdomen and push it upward in the longitudinal line. You cannot push it anywhere. There is a direction in which you will push something. You will push it upwards towards the umbilicus, because I'm going to replace it to the normal position. This is called, if you remember, that's very good. This is Johnson's maneuver. It will tell them that you know what you are doing. After putting it in the place, what you will do, um, after this, if there is a constriction ring is palpable, then pressure would be applied to the part of the fundus which is nearest to the ring. Like if there is a constriction ring and the uterus is downwards, then you will apply pressure near the ring so that gradually with one finger you will try to move it upwards like that. That is one thing, okay? If we cannot do this manual replacement, then what you will do, we will try to give the relaxants, like the nitroglycerin can be given, terbutaline can be given. So they are like uterine relaxants, and after that we can just, if it is relaxed, yes, then we can do that. Sometimes if these things are not available, then the gases are available um, in the delivery on the delivery suite. Like we are giving nitrous oxide to the patients all the time, so you can give them that thing, or you can give them isoflurane. So patient will inhale. This is also a relaxant, okay? And then we can put the uterus back like that. Halothane gas is also very effective, so you can put it in place. That is one of the things. So then if it is not occurring, then what you will do, then you can use another method like that. So what you will do in that one, here what you can do is that you will see that where is the inversion. Then you can place the pump, vacuum pump, the same like we are using for the delivery of the baby. Put that one and then give warm water. Okay, warm water and then placing it. Sometimes what happens, it will push the uterus back upwards like that. Anybody remembers what is the name of this procedure?
Actually, today I forgot all the name of procedures.
Yeah,
I can't
it happens
recall.
all the time.
Yeah.
So first one was Johnson. So what is this one? Like you are putting the vacuum, running the hot water and trying to push it back. Okay. So this is the Huntington's procedure like that. Okay. This is the
What is
Huntington's procedure. The Johnson was the simple placement like that. Okay. This is not Huntington's. This is like, I think, the Horton procedure for that one. No, not the Horton like that. It also has a name, similar name. The first one was Johnson. So you can say that, okay, forget the name of the procedure because there were four names. Okay. So just with the pump, try to push it back with the water relaxant pump. If it is not occurring, then you will go to the secondary methods. So the first one is also okay. That is also Johnson's method, that do it manually, or you will just take the gases and then you will put with the left hand inside the same procedure. So this is Johnson's, but you are doing with the help of the anesthetics now, and then you are putting like the what. Then we will go to the secondary interventions. The first one, Johnson. Still, we have not ignored that part when I said that we will put the pump. I also mixed up. Just Johnson, first without anesthetic and then with anesthetic agent, and then try to push it back. The gaseous anesthesia. Nothing happening, then you will say, then I will go to the second line procedures. Second line procedures, remember there are two procedures. One is the Huntington's procedure, and the second one is the Haltane procedure, and then we can have other options also. So what do we do in the Huntington's procedure? You will see in the when you will do this Huntington's procedure, when the uterus is prolapsing, the cervix is left up in the upper part. Why? Because cervix is attached to the bicaudinal ligaments and the uterosacral ligaments. It is attached to the surrounding bones structure. So it is strong, so it will not come down. Okay. So but the uterus is soft, so it will come down. So you will see that where is this ring is there like that. Okay. And then you can do this one here. You are going, this is less invasive. Okay. So you will try to push the things up like that. Not, it is not working, then you will have to go for the laparotomy. The secondary interventions are through laparotomy. In the laparotomy you can do two procedures, Huntington's and Halton's. In the Huntington's, you will locate that where is the inversion of the uterus. Now you are looking from the above, and the uterus has gone below the constriction ring. The constriction ring is made by the cervix. So what you will do, that you will gently try to pull it upwards towards the normal position, that would be towards the umbilicus. You can gently pull it with the help of the clamps. Usually two LS forceps are applied on the sides of the fundus, and then we are gently pushing them up like that. That is one thing. Okay. If it doesn't work, then what you will do, because the constriction ring is very tight, then you will have to increase that about 1.5 centimeter, usually in the posterior surface of the cervix or the uterus, to open the constriction ring, and then we are pulling it upwards like that. Okay, this is called like the manual reduction you have done, and the incision that obviously we have to repair that like that. So these are the things that you are going to do for this patient. Another thing, like we said, was that would be like we are doing. Um, if you don't want to go for surgery, because these three procedures we are doing most of the time. If these are not working or you don't have the expertise for doing it, then another method is that we will just take this vacuum and attach it to the warm water and try to give pressure from below, and then keep your hands on the sides of the vagina to create a seal. So sometimes under the effect of the hydrostatic pressure, the uterus will return to its normal position like that. And usually it will take some time, and 2 to 4 liters of the fluid they are used, but everything is externally. It is everything is happening externally like that. Okay, that is one thing. So four procedures: Johnson's, then laparotomy procedures, and if you don't want to do any of these procedures or the Johnsons have failed, then you would use this hydrostatic force to return it to the normal position. No, it will not stop here, because you have just push the things back. And remember, Fatma also said that when you see the patient, if he is getting eutotonics, first action would be to stop them, then give the oxygen and start do the needful like that. Okay. After that, you will say, after replacing the uterus in normal position, I will like to do management of the placenta. So what will you do for the management of the placenta? Of course, you have to remove the placenta, and you will say, I will not remove placenta unless the uterus has been replaced to its normal position like that.
And
If they ask you that why you will not do that, because I just told you people that if we will remove the placenta, there will be severe hemorrhage. We are not giving the uterotonics. See how large is the placenta? The surface area is so large, so your patient is going to bleed like hell. So just put it back, and after that, what you will do? You will put your hand. Sometimes, by that time, if it has to come off, it would have come off. So it is not coming off. That's why uh, it occurred in the first place. Two reasons, like Fatma said. One is the Craddy's maneuver. We should not do that. If somebody did that, what is Craddy's maneuver? That the midwives sometimes what they do, they start pushing the fundal pressure and they start pulling the placenta on the other hand. So this is a sure recipe for disaster, which is called uterine inversion. They are pushing from above and pulling from below the placenta. It should be avoided. Okay. So sometimes the placenta is adherent. So just you have replaced it back, start the uterotonic, put your hand inside, and the other hand you will place on the uterus, but you will push it upwards, not downwards, okay? On the just above the pubic symphysis and put it upwards, push it upwards. Then with your fingers gently, you will try to make a cleavage plane between the placenta and the uterine wall. Okay, so eventually, what will happen? You will gradually go and you will take the placenta out, you will separate it, and then you will take it out like that. Okay, so if it doesn't occur like this in this way, then of course you will have to take her to the OR and you will have to do the MROP, manual removal of the placenta under anesthesia like that. Okay, so you have just kept the uterus in the normal position. You have removed the placenta, and then you are going to run the uterotonics. And after, so you will give the first dose of the oxytocin, and after that you don't forget to say that you will run oxytocin infusion. How much oxytocin will be there? The ACOG says that you should run 20 to 40 international units of oxytocin in 1 liter of crystallized fluid, and you should be giving like 150 to 200 ml per hour. Usually we try to give that, run that for at least 4 hours like that. Okay, and you can increase the dose, you can increase the rate. Dose you will not increase, you will increase the rate or decrease the rate depending upon the response of the patient. So if you cannot use, if patient is not responding to oxytocin, remember, primarily, if you will go to the classification, uterine inversion is telling you, giving you PPH. Nothing happened, then you go to carboprost. So 8 doses can be given, 25 to 150 microgram intramuscularly, which is in most of the cases we are giving directly into the uterus. And at 15-minute interval, you can go out, give up to 8 doses. And the total dose at the end would be 8 doses of 250 micrograms. So you are giving her total 2 milligrams. This is so potent. If that didn't work, escalate the level, give them misoprostol 800 to 1000 micrograms vaginally. Okay, rectal administration is even better because there will be no blood. So if it is there is excessive bleeding, then give it rectally for the action. So if your patient is not responding to the misoprostol, then you will go and you will give them dinoproston. Dinoproston, usually they will not ask you about the dose, but the dose is 20 milligram. You can give again both vaginally or rectally. If that is not working, then again you are going to give them methyl ergonobin. That is a form of the project of the what we give methergine. Okay, that is also a form of the methergine. So you can give 200 microgram intramuscularly every 2 to 6 hours, and maximum 4 doses can be given. So usually all of these things they are going with that they are going to be fine. But remember that if the patient has asthma or he has COPD, then you should not be giving two things. Don't give them what you will not give to them.
Prostate
Carboprost,
alpha.
and that is a contraindication. But remember, these are relative contraindications. Okay, and methyl ergonovin, you will not give this one also. So now, once you have done extensive manipulation, so will you like to give her antibiotics? The answer is yes. We will give her single dose of first generation cephalosporin. Okay, single dose first generation cephalosporin. Like you can give them cefazolin can be given for. Why are you giving it? For endometritis prophylaxis. Give that for endometritis prophylaxis because it is going to cover or, and you can also give, if you don't want to give this first generation cephalosporin, you can give them clindamycin, you can give them gentamicin because this combination is going to cover gram positive, gram negative, and anaerobic bacteria. But you will say that you will give antibiotic prophylaxis against endometritis, uterine endometritis. That's why we are giving it. So then you can say, I will counsel the patient that there is a risk of re-inversion. Okay, re-inversion can occur. So she needs to stay on the hospital for like a day or so. and we are just going to observe her, and then we will counsel her that she should not be lifting weight. If she sees any abnormal masses at the introitus, she should come back to the hospital. If they ask you that what other complications the patient can have in addition to the postpartum hemorrhage, then like Fatma said, this woman will need blood transfusion. If the external maneuvers they are failing, like the Johnson's maneuver, then the patient will have to go for laparotomy. Sometimes even with laparotomy, the things are not happening. She's not responded. Like we couldn't place it back. So in view of the torrential hemorrhage, the patient can go for hysterectomy, hypotension, shock, death. All of these things can occur. And then, do you think that what is the risk in the next pregnancy? We don't know. We don't have any studies to guide us. Okay, because they can ask you that the patient is asking you, what will you do for the next pregnancy? We don't know. We will just tell her that she should have hospital delivery and we will do active management of the third stage of the labor. That is all you need to say. Usually, if you have a patient like this, what will you like to do for them? You will like to see that if she is having any risk factors. Okay. So, what do you think? What can be the risk factors? Actually, the risk factors they are absent in more than half of the patients like that. Okay. It may occur in a patient who has placenta previa carita. Okay. One with the history of the PID. Okay. Then if somebody has these leiomyomas, that is one thing. Okay. And then if somebody has a short card or the baby is very large. Okay. And rapid delivery, this is tricky. Precipitate labor and prolonged labor
Mhm.
and retained placenta. Okay. One very rare example will be that of the Ehlers-Danlos syndrome, where the tissue is not like very strong like that. Okay. Tissue is very elastic. It's not strong. So what will happen? They can have this prolapse uterus like that. Okay. And then rest of the things, yes, I will agree with you that there should be this debriefing of the patient because this is something very frightening. Then there can be clinical governance, risk management. Risk management, for that, you don't need like actually something to happen. You can say that this thing has happened. So we should be ready to deal with all types of emergency stuff like that. Any other problem, anything you would like to ask me or say?
Yeah.
If you will
دكتورة
go if you will go to obstetric emergencies, you know, key to all of these stations is given over there. Like, okay, okay, thank you very much. Okay, this one
دكتورة
is for
Spinelli operation is the same, the one with the hydrostatic pressure or the one with the vaginal approach?
uh, the Johnson you are asking me.
No, not Johnson. Spinelli operation maneuver.
Which maneuver? Sorry, forgot.
Benelli maneuver.
No, that is different. Na? Johnson is when
This
you
is
are
the
going
one,
with. Yeah, Jensen is the
not I
one.
mean Johnson.
No, no,
The
no.
Spinelli, the one, the vaginal approach and the
Yes,
cutting.
yes.
That's okay,
Yeah, and Horton and Huntington. Huntington first, and then Horton. Okay.
okay.
So basically, just four maneuvers. So you are not required to remember the names, but if you remember, that will be easy for your this procedure. That is one thing. So can we go to the next station, please? Fatma, are you there or left already? Because all of you are not on vacation. That is the thing. I'm just trying to facilitate that all of you can have the chance here.
I can go دكتورة if دكتورة فاطمة
Okay.
interrupt or دكتورة رقية will continue.
Yeah, better Dr. Rukaiya. You know why? Because
Okay.
she came first. Okay. So,
Yeah. Okay. No problem.
thank you. Okay, dear. Take 2 minutes,
Okay,
then we will
doctor.
start about.
Okay, doctora.
Okay, dear.
Okay, first I will come to the delivery room. Inside the room, I will introduce myself to the patient. I will ask the nurse about um, her cervical dilatation.
Mm-hmm.
Okay, and I will ask her also the brief history about the patient. She's gravida bara, she's term or preterm, what is the estimated fetal weight? And yes, also if she term or preterm labor, rupture membrane or intact membrane, where is the presenting part?
Mm-hmm.
And then I will assess patient vaginally. Then according to the finding, I can discuss with the patient. We will discuss with the patient after examine her. If still يعني not fully and membrane intact, we will discuss with the patient about the mode of the delivery for her. If she's term, the baby between 2.5 till 4 kg, and we will discuss with her. She has two options: either she will go for breech delivery, and we will explain for her the risk and benefit, and order she can go for if she's in labor like emergency cesarean section.
See here,
Uh,
she's in. See here, she is in advanced labor. Okay, so she's more than 6 centimeter dilated, and this is like a complete breach. So, what would you like to tell her?
like even 6 cm still we can, except if she's fully and bodalic already plus, I will go for breech because it also depends on the experience of um the obstetrician. We will tell
Yeah,
her about the يعني for if they want vaginal assisted delivery. Uh,
yeah,
for,
assisted
for
vaginal breech delivery. Yes, we can.
Okay, okay. Just we will inform. I will at that time. I will
Mm-hmm.
inform. I need we will call for the midwife, the pediatrician, and the consultant also. I will tell the nurse also to prepare the instrument, the forceps after coming head for the breech, and
Mm-hmm.
warm towel for her in the beginning, if she's complete, yeah, either will like spontaneous delivery till she will reach the umbilicus, or we can extract the foot of the baby and do the Binard maneuver to deliver the leg of the baby. Then we will cover the baby with a warm towel, and we will handle the baby, our thumb in the sacrum of the baby, and the the index finger on the anterior superior iliac spine to not injure the baby and make hip dislocation. We will make spontaneous till we'll see the umbilical cord. We will release the pressure in the cord. After that, we can pull the baby till we see the shoulder of the baby. We will do the
Mm-hmm.
left set maneuver to deliver. First, we will deliver the first arm. We will rotate the baby on anterior 180 degree, and we will remove by entering our index finger to the arm of the baby. We will remove the first arm by the left set maneuver, then the another arm. At that time, we will ask the nurse to make pressure on the suprapubic to make the head flex at the time while entering the pelvic. Till we will see the neck of the baby, we will do Marshall, I forget the name, the maneuver. We will put the two, um,
Marshall
the
Burns. Yeah.
index, yes, the
Marshall's
index.
very sweet can also be done. So,
Okay, we will. the index and the middle, the ring finger on the maxilla of the baby and the middle finger on the mouth, and we will extract the baby, or we can extract it by the forceps. Yes. After that, we will handle the baby to the pediatrician. We will take the cord BH for the baby, and we will make the active management for the third stage. Then we will inform the patient, debrief for the patient about the breech delivery. In case if we have difficult delivery for the head, either sometimes is الهيد not deliver, we can do recent procedure to cut the cervix to deliver the baby. What else about the breech?
Okay, so if you are cutting the cervix, at which point you would like to give the incision?
Either 2 or 8.
2 or 8. Why? At which point the arteries are entering? Okay, you can give two, 2 or 10, and
10,
then
sorry, not 8. Yes, صح.
yeah, then 4 or 8. Okay, because the blood vessels are entering 5 at points 5
3
to
and 9.
7 and 3 to 9, like that. Okay, that is one thing. Just avoid them. Okay.
Okay, and I forget also in the beginning, I
Mm-hmm.
supposed to I take verbal consent from the patient, because we will
Yeah.
explain for her the risk for breech delivery. Maybe we have
Mm-hmm.
sometime a hip dislocation, injury or stuck of the head. By the forceps, we have like cephalohematoma or facial injury, and we will empty the bladder, and it's supposed to be a rupture membrane fully dilated at the time delivery of the breech.
Yeah, that is also
And
one
then
thing.
we'll document everything in her file.
Mm-hmm. You will take paired cord blood samples or no need?
I will take it.
Yeah,
I
take
told you I will
paired.
take it.
All emergencies, just take
For,
a paired
for
cord blood
the breech and
samples,
the emergency, yes,
and
we will take.
yeah, and the complications the baby can have because of the breech presentation. What complications the baby can have? Their breech.
Uh, for the breech,
Mm-hmm. The same brachial plexus injury. Okay, fracture of the long bones. That is one thing. Soft tissue trauma. Okay, and then head can be bent to one side because of the excessive pull on the head, or and the neck can be bent towards one side, torticollis. Okay, that is one thing. Mother can have PPH, and mother can also have what? PPH,
third
and the
and fourth degree
perineal tears.
laceration.
Like that. Okay, that is one thing. Or she can be like too much scared, and the biggest fear is that of the death of the fetus. Like that. Okay, that is one thing. So again, for the breech, what maneuvers you are doing, the names, yeah, you can forget, but you should do the things in the right way. So you have undiagnosed breech, so this is an obstetric emergency. Okay, she's advanced in labor, so you will like to go and you will like to review the patient, that what is her full name and the date of birth, and ask her about the previous deliveries. That out of three deliveries, they were normal births, or there was any cesarean section. Was there any intervention done, and how are the babies doing now, like that. Okay, that is one thing. Then the second thing you will like to confirm is period of gestation. Okay, because for the preterm breech, still the better mode of delivery would be a cesarean
Cesarean.
section. So exclude that this is not a preterm breech, like that. Okay. So then you should remember, you will say this is an emergency. This is something very serious because it is breech births. They are associated with increased chance of perinatal morbidity and mortality. Okay, that is one of the things. Because these babies, why they will be breech? Because there is something either wrong with the placenta, with the uterus, or with the baby itself, like that. Okay, so already there is some expectation that maybe the baby will be IUGR, or maybe with some anomaly, or maybe multiple pregnancy. So again, you will like to confirm that this is a singleton pregnancy, like that. Okay, I will do the abdominal examination to see that where is the head and where is the back located, like that. Okay, that is one thing. Then with the permission of the woman, I would like to do the VE. So on the VE, what will you like to see? You would like to see that there is no cord prolapse, because the breech usually till the time of active labor, it will not it will not be fixed properly. Okay, so you will like to see that the membranes are intact or not. In the abdominal examination, also document what is frequency, strength, duration of the uterine contractions. On the VE, again see that what is the degree of dilatation, what is the position of the cervix, soft, effaced, or like what, membranes are intact or not, and where is the presenting part, what about the liquor, is there any blood, is there any meconium, because if the membranes are ruptured, then you are going to have the meconium, which will be normal finding in case of the breach. Then you will like to see that has the CTG been cited and how is the CTG, like that. Okay, very important in all emergencies, because they will help you decide that what should be done next. After that, what you have to do is you will check that mother has been given some analgesia. If he has not been given, you will ask her about the choices and you will like to give her analgesia. Analgesia can be given in the form of the opioid anesthetics, or opioid drugs can be given, paracetamol can be given. You will use the latter. First give paracetamol, no benefit, then you will give her opioid analgesics. And if she's still feeling pain, then he has the option for epidural, and epidural is a good choice here. Why? Because if you have to escalate to the, you have to go to the cesarean section, then we can just do the top up and go for the section. After initial assessment and determining that what type of breach he has, and this is a term breach, then you would like to inform your consultant. You will say that this is an emergency. We are having a patient with breach and she is about to deliver, or you will tell that how far she is dilated, like that. Okay. Then you will also like to inform the neonatologist. Okay. And you will be like to alert the anesthetist also, because maybe we have a patient with breach, so maybe we will come to the OR, like that. So tell the mother that don't push unless you are fully dilated. If the patient is already fully dilated, you will say that I will bring her to the edge, bring her buttocks to the edge of the or end of the bed. I will tell her to take deep breaths with contractions, and she should not push unless the buttocks of the baby they have descended to the introitus and she has a strong urge to push. That is one thing. Okay, so what you will do, you will wait, like you said, that the warm towel should be there, everything should be ready, the pediatrician should be inside OR, a person trained in the breech delivery should be there to supervise you. He can do, or he can give you a chance to do that. Okay, so you will wait till the buttocks they have come out. Once the buttocks they have come out, you will only support the perineum. No touch technique for the baby. Once the buttocks are out, then you will help to deliver the legs with gentle pressure. You will apply gentle pressure on the inner part or the medial part of the femur to bring the legs out. One by one, both legs will be out, like that. After that, you will see that where is the back of the baby. Your aim will be to keep the back of the baby towards you, like the back should be towards the upper part. Then you will let the baby come out, and I will hold the baby at the bony points, because the babies are so delicate. Okay, even if you are holding the buttocks, you will try to hold the pelvic bone, hip bone. Never hold the soft tissue, because we can traumatize the organs of the baby. So we have to be very gentle, like that. So the further descent, where till the point we can see the hairline or the nape of the baby, like that. Okay, then I will try to deliver the shoulders, and to deliver the shoulders, the baby should be in anterior posterior position. Because if the baby is transverse and the back is towards you, so you cannot deliver the shoulders. Okay, and then you will rotate the baby. First deliver the anterior shoulder, then deliver the posterior shoulder. So that is one thing, you can do it gently. Okay, so how we can bring the humerus down? You will gently swipe the arm of the baby with the two fingers. You will swipe the arm and you will try to pull it out like that. Okay, so the arms have come out. Now the baby's face is approaching like that. Okay, so Martius-Pelly Wheat maneuver is commonly used to deliver the head. What do we do here? We use our index and middle fingers. We are going to place on the maxilla of the baby. You know, the maxilla is the upper part of the face. Put two fingers on, one finger on each side of the nose on the face of the baby. And the index finger and the middle finger, because baby's face is small. You are putting two fingers on the head and you are going to flex the head of the baby, and then you can keep like one finger in the mouth and two fingers are on the side of the maxilla like that. We will bring the baby down so that we can see it, and then after that, once the head is out, then you are going to use the track maneuver, which is you will take the feet of the both feet of the baby and you will flip the baby towards the tummy of the mother like that. Now you see the back was towards your side. So in a semicircle, you put two fingers of your right hand on the face of the baby. Face of the baby was towards the sacrum. You put two fingers on the maxilla, upper part of the face. One finger inside the mouth. This was to decrease the flex the diameter of the head, and then pull it out, and then the Pratt maneuver, lift the baby towards the tummy of the mother. With that, we have just accomplished the delivery, and now the baby is out like that. Okay, so that is the thing, and after that you will do the clamping of the card. Okay, they will cut the card and you will wait for the uh, delivery of the placenta like that. Okay, so you should not be like too much worried about the maneuvers. They don't want to ask you about these things, but you should remember that these are the essential maneuvers that we are doing for delivering the baby like that. There are many other like the BRAC maneuver. What do we do? This is also like spontaneous delivery. Now we are not doing anything. We are just letting the baby be delivered. Pinard maneuver, it means that we are going to flex the hip of the baby and to feel and grab the foot for the extraction. That is the Pinard maneuver. And sometimes if the head is not coming, then we will have to use the Piper's forceps, because they don't have this pelvic curves. They are just straight forceps, so they will not interfere with the delivery of the baby. That is one thing. There is another important thing, that what time the buttocks came out and what time the head was delivered. Okay, ideally it should occur like within 2-3 minutes, because otherwise the chance of having this asphyxia of the newborn and the hypoxic ischemic encephalopathy, the risk will increase. So you have to mention all of these things. So active management of the third stage of the labor, just run this syntocinolones and wait for the signs of separation of the placenta, take them out, observe the mother for the perineal tears, and keep her under observation and look for PPH. Observe her that she doesn't develop PPH. After the event, what we have to do, like baby should have been seen by the neonatologist, full examination should have been done, and if there is any problem, we'll be addressing that. The baby, like it has told you before, the baby can have the brachial plexus injury, or baby can have the fracture in the long bones, or there can be head injury. If the baby is the problem is that sometimes if the baby's birds, they start moving downwards, mother is pushing. Okay, then what will happen, the butts of the baby, they will pass through the cervix, but the head won't pass. In that case, you will have to give lateral incisions. We call them durains, dusrains. You can use many names. Incision, that is to cut lateral incisions. Don't give incision at 3 or 9 o'clock, but you can give incisions at 2 and 10 o'clock positions, or you can give at 4 and 8 o'clock position like that. Okay, after delivery of the baby, you will complete the third stage of the labor. Regular observations. Baby would have been seen by the neonatologist. Debrief the mother and tell her that it can happen to anyone, not her fault. The baby is fine, or the baby is going to improve with passage of time. If she will have any questions, I will invite that. And consent of the woman is very important. If at any stage she says that no, she doesn't want a C-section, we will not do that. If we will do that, that will be battery and assault. Document everything with a timeline, and you are going to be fine like that. So you know, you got any question, anything? Okay. So you need a break to offer prayer or what?
Yes, دكتورة.
Okay, dears. Take a break and then come back. Thank you.
This conference will now be recorded.
I will start first. Identify the what's going on. What's the issue there? Why it's happened? Was it could be available? It could be avoidable. I don't know, unless I have all the answer. And then after that, I would go for risk analysis. I would do simply quickly root analysis and why it happened. Like, root analysis. What's the issue there? Was the issue with our شو اسمه هذا do analysis. I will check the patient risk factor such as obesity, hypertension, big baby, failed شو اسمه failed. What's the did we try to do vacuum delivery? Was it failed? Was it failed? Why was it failed? What's the cause of her failing? Was it due to patient condition or fetal or training issues? After that, I would do for okay. I will just I will check if after that if I once I answer all this question, I will just put we can do just simple reporting or simple or just ask could be available or not. Abbreviation next time, what to do for next time. Maybe to call maybe this patient need to check with the issue how to prevent it, and so to prevent it and this is it. No, nothing. And then I will we'll see if we can do something more, and if something wrong with our protocol, and we need to do if something wrong with our protocol or or in our hospital, we do audit. We'll need to audit to see to audit after the 6 month. Which after 6 months we do re-auditing, in which that we see was it after implanting the new standard, the universal standard, was there's improvement or not? Okay. What are associated maternal and risk maternal and risk maternal risk is that risk of bleeding, risk of bleeding, risk of injury, risk of bleeding injury, and risk of bladder injury, risk of bar injury, risk of adhesion, risk of infection, risk of the infection in next pregnancy, and cosmetic appearance of the abdomen, and this is risk of infection during injury, risk of DVT, and risk of cardiovascular event, and maternity risk of risk of in ICU admission, risk of hematoma, risk of cephalohematoma, risk of in ICU admission, risk of hypomagnesemia, hypocalcemia, hypocalcemia, risk of meconium aspiration syndrome, risk of neonatal TTN, and risk of intubation and risk of cerebral palsy, and risk of patient risk of cerebral palsy, and infection, and jaundice. There's nothing else.
Yeah.
What's the optimal management for the section at full dilatation? I don't get this question, doctor. What the meaning? Optimal management for the section.
It means that what steps, what precautions, this is to trick you, what precautions you will take when you are doing cesarean section for full dilatation, at
Okay,
full
the full
dilatation.
dilatation. So, first I will inform the consultant call that we might need in OR, and I will inform the anesthesia in call we might have difficult surgery, and you might need have to do anesthesia complication, and you might to type with possible anesthesia complication as maybe patient could be not in BO or should be BO, and we give the patient for sodium citrate to reduce the risk of aspiration, and in ICU we inform the ICU about the case and possible and the need of intubation and possible, and we need a possibility if needed senior in ICU doctor, and we take the consent. We need to inform consent about risk of bleeding, risk of infection, bleeding, laceration, injury to bladder, bowel or ureter, and risk of extension, and risk of extension, risk of blood transfusion, and risk of endometritis, and we need to cross match unit back to prepare the patient to line RBC and risk of postpartum hemorrhage. We need to recent CBC, cross match or standby to unit back RBCs. Prophylactic, antibiotic prophylactic as per protocol, 2 gram IV cephalosporin, depends on the weight, and when you open we do the abdomen we do the abdomen in sterile manner, and sterile manner with the abdomen in layers, with taking precaution of opening the uterus higher opening as the cervix is fully dilated after pushing the bladder down to reduce risk of bladder injury, and possibility of and after and with possibility of difficult delivery, and from that after delivery the baby we need to take we need either if the patient is crying we can do if the patient CTG was unstable we need to do early cardiac clamping. If no CTG we can wait for 30 seconds to 4 minutes for early cardiac clamp, and we take fetal pH for legal documentation, and we close the uterus in layers as in 2 layers, and we close the visceral and parietal peritoneum and by as per protocol, and we close the abdomen and skin layer. Nothing else. And we want to mind that while delivering the head, we might need we might need someone to push the head from down, as could be very down and engaged there with difficulty of delivering the head, as and with difficulty of and possibility of cabot succeedum and or molding, and to ensure which is could increase risk of infection and risk of الحمد لله رسول الله uterine اسمه uterine incision, and this is it. You're expected to answer.
Yeah.
And
So what are the complications? What is this patient at the highest risk?
highest risk right now, risk of this patient risk of risk of BPH, and the risk
Yeah,
of
PPH 10 times higher, okay?
yeah,
What
the
other?
risk of
Yeah. So let's say that if she, like for the delivery of the head, you said that you can use pushing methods, pulling methods, or Patwardhan techniques, okay, like that.
mm.
So which one you like to use and why?
Um, so pushing method or using bullying method. I would like to use شو اسمه هذا bullying method at sometimes bullying method or delivery of non-cephalic presentation as to reduce risk of bladder injury and extension as the pushing head from down sometimes could cause pressure on our thin segment of the uterus, so could lead to extension of the injury, of extension of our incision, which could lead to bleeding and risk of
Extension.
yeah, extension and risk of bleeding, risk of transfusion, and risk of ligation and hysterectomy, and risk of hysterectomy.
Yeah, these are the things. Okay.
Mm.
So you can use any of the methods. In the pushing methods, your junior will use a gloved hand and they will push the fetal part gently upwards without dislodging anything. And you will also use your non-dominant hand, the four fingers. And when your fingers they meet with the fingers of the pusher, you will gently flex the head and take it out with your non-dominant hand. Okay, and the
Mm.
rest of the body will follow. In the pulling method, what you will do, you will move your fingers your of right hand, you will move along the body of the baby because the now head is fully engaged. Okay, you will try to hold foot of the baby and you will try to extract the baby with the legs, okay, as a breech. In
Mm.
the put person technique, what they do is, so when you're using this pulling method, then you are also avoiding unnecessary stress on the lower segment of the uterus because we are trying to prevent the cervical lacerations. Because the thing you are seeing now is not uterus, that is the cervix, because it has also
Mm.
thinned out and stretching, which you can see in the abdomen like that. That is one thing. So pulling method, just hold the leg and gently take the baby out, and then in the end flip the head and take it out gently. But Putwardhan technique is
So
that,
we have to we can call it pushing method and pulling method. This
yeah, pushing
only two
methods and the pulling methods. And
mm.
another pushing method is that you can use the pillows. Like they will
pillows.
put up some device like the pillow, it will some simply inflate and it will push the head up like that. Okay, that is one thing.
Mm.
So then another method, the last one, they say that it is also very safe. That is the Patwardhan technique where you can deliver the baby as breech or by the leg, and you are leaving the shoulders of the baby behind. And in the end, and then you have pulled out the rest of the body. The shoulders are in place. Then you're removing the head, followed by the shoulders like that. Okay,
Mm.
but you can say that Patwardhan method is also like a pulling technique like that.
Mm. So we have
You have
pushing,
pulled that,
pulling, and pushing
yeah.
deep as
Like that.
so
So
we only need the headline. The headline. We say method
yeah,
pushing,
just say the
pushing method, and
pushing
pulling
method
method,
and
and
the
device
pulling
breach.
method. You're going to be fine with that, okay?
Again,
After
Doctor, sorry, the three
that,
method, pulling and pushing.
and the put burden technique. Everything, you people are not reading the notes. Everything is written in your notes, okay? Everything is given in the notes. So, but I understand that you can have like the problem with this one, you are like busy and you are doing the courses and studying, but just if you will go to the notes, really you will find everything. So what is the Patwardhan technique? This is a unique technique to deliver the babies in the second stage of the labor, okay? And this is um, it is as safe as the traditional pushing and pulling techniques like that, okay? That is one thing. Patwardhan technique also like that, okay? So what happens here is, like I've just told you, since the baby's head will be impacted, okay, and you don't want to do this push method, you don't want to have this pull method, what you can do is you can use the Patwardhan. In the Patwardhan, this is like the shoulder first technique also like that. He says that leave the head behind, take out rest of the baby, and then in the end the head will follow like that. Okay, that is his method. So this is as good as any other pushing or pulling method like that. Okay, that is one thing. So that's all you will tell them, and then you need to tell them that the patient can have other problems as well. Injury to the bladder, injury to the viscera. So after delivering the baby, and this is a case of like a bit obstructed labor. It will be like that. So you will inspect all abdominal viscera, look for any sign of bleeding. Then you will secure the edges of the incision, and then you will proceed further. So regarding, I will tell you again that this pet burden technique, mostly, when the babies are not coming, imagine, um, long case of obstructed labor. So mostly it will be because of the occipital transverse position or occipital posterior position. That is one thing. Sometimes occipital anterior. Okay. So what happens? The head is deeply impacted like that. Okay. So even in the occipital anterior position, if the patient is not progressing well, then the head is stuck behind. Okay, so it's prolonged impaction. So there will be blood in the urine, impaction because of gradually the head is coming. It is hitting on the bladder and the rectum and everything. So these areas they will be very much edematous. So if slight injury there, it can lead to massive extension like that. Okay. So this Putवर्धन technique, what is this? That you have done the lower uterine segment incision. Okay. So they say that what you can do is this method. First, deliver the anterior shoulder, deliver the posterior shoulder. Okay, then with the hand, what you can do here, how you can lift. For the anterior shoulder, put your two fingers on the shoulder and bring that shoulder out. Okay. Then try to bring the other shoulder out. The head is still inside the pelvis. After the shoulder, lift the buttocks, lift the legs of the baby like that. Okay. And then in the end, head will automatically follow. Just remember that shoulder first is the Patwardhan technique. Okay. Shoulder first. First of all, you will deliver the shoulder, then the body, and then in the end, you will bring out the head. But basically, you should know that there are conventional push methods and pull methods. These are the things like that. Okay. The push method, we have the most experience with the push method like that. Okay. Still, you have to be very gentle like that because of the risk of the extension. The pulling methods are also equally, and interestingly, all of these things are equally effective. Okay. So you are going in the pulling method, the push method, that someone is helping you. Pull method, you will have to say that you will move your hand up in the upper uterine segment. Okay. So each of these methods has its advantages like that. So once the baby has been delivered, call the NICU people are already there. I told you that in all emergencies you will request double cord blood samples. Okay, it should be double cord blood samples. Proper documentation. Baby at risk of transient tachypnea of the newborn, as well as there can be hypoxemia. Why acidosis? Why? Because the procedure has taken some long time. Baby can have some injury like that. Okay, or baby can be macrosomic simply. After that, removing the baby, pay attention to everything. Where is the placenta? Let it come off and secure the edges. You can secure the edges even when the placenta is inside the uterus because you don't want to have massive bleeding. So secure the edges, take the placenta out. The bladder is being already drained because the catheter is there. And give the uterotonics. Close the uterus in two layers. Second layer we are doing to bury the first layer. Secure hemostasis, look at the pedicles, look at the peritoneal cavity, always ask in any surgery. You are doing episiotomy, make it a habit. I will ask the nurse about the counts, needles, swabs, okay, any instruments. All the things are complete. We actually, the good manners are that before closing the rectums, ask the nurse, the scrub nurse, can I close the practice? Please tell me that the needles, the towels, and the instruments, the counts are complete. You know, the counts are done twice, and who is doing the counts? Roaming nurse and the scrub nurse. Okay. Sometimes I know that we are working with other people. Sometimes we can face the bad attitude of the others, but forget it. Okay. Don't make it a point or an ego point. Ask her things are fine, because this is for the safety of the patient, like that, and that is our ethical responsibility, our responsibility as a human being. Okay, that we should be civilized, big heart, forget the ego, and just ask her. Counts are complete. Needles, instruments, towels. Okay. Can I proceed to close the rectus? Nobody will ever say that you didn't ask, and that's why now the patient has problems, so you are in trouble. That is one thing. Second thing is, you will say that during the surgery you will keep the needles. If you need to hold the needle, you will use the needle holder. Don't let your needle wander around. This is a good practice point. Always keep the needle in the needle forceps. Okay, these tiny things, they will take you a long way. They are very helpful, so that the patient will not have any unintentional injury, anything like that. Okay, all pedicles are fine. No oozing in the abdominal cavity. In cases of obstructed labor, the patient can have a ooze, especially the patient who received prostin for induction of labor and now you have done the cesarean section. So you would want to leave behind a subrectus drain. If you have to leave a drain at all, then go for the wider caliber this drain, so that it will serve its purpose. Okay, and fix it, and then take a note in the notes as well. Close rectus subcutaneous fat is more than 2 centimeter. You will close that as well, and then do the subcuticular to the skin. VE, in now the world is moving towards this side, that you don't have to do the VE or anything. But if you clean the patient, it's good. Okay, because this will not be collected behind like that. You have done the second stage cesarean section, you are going to give the double antibiotic to the patient. You can give cefazoline, or you will have to give the clindamycin and gentamicin. Why gentamicin? And you will have to use the metronidazole as well. Why? Because multiple metronidazole with cefazoline, as well as with the other combination. Why? Because we have done multiple examinations during the labor. Okay, that is one thing. Should be given for 5 days. That is one thing. Okay. The injections should be given for the first 24 hours. Then she can be shifted to the oral drugs. Okay. I will document everything. I will help with shifting the patient. I will document everything with a timeline accurately. Okay. And the debriefing of the patient is also very important. That what were the circumstances. So depends that why the head was not descending. Sometimes there will be only this short cord. Sometimes there can be other issues. So whatever was the issue, I will like to explain it to the patient, and that we did it to keep her and her baby safe. That's why we have done it. I will invite questions, and I will reassure her like that. Okay. These are the things that you should be telling your patient like that. Okay. Any
Dora, about the
question?
question, yes,
Yeah.
about the question was, is this avoidable?
So you can say that, yeah, such things actually are avoidable. Okay. You ask me why.
Yeah, because sometimes we can avoid, but maybe either will affect on the baby or maybe unnecessary cesarean.
How we could have avoided?
The cesarean, either I will use the vacuum,
Hmm.
but sometimes even failed vacuum, we suppose mandatory to go for emergency, second stage of labor.
Yeah, you will say early identification of the dysfunctional labor, and having and using instrumental delivery, assisted vaginal delivery. Now the new name for the this operative vaginal deliveries is assisted
Yes.
vaginal delivery. Okay, if you have the expertise in that, you can do that. Okay.
Okay, but like this question, yeah, for the for station number 8 يعني in the exam if I cannot recognize he want the dictation of the OR
But you don't recognize?
because the station for dictation of the OR also صح and
Yeah,
the maneuver
definitely. Yeah.
if I just said the maneuver that's enough or sometimes the examiner he will guide me to said
No, yeah. If they have a dummy, they can ask you. If they will bring a station like this, they will bring a dummy as well. In each hospital, what do they have? They have dummies.
okay
In your hospital, also go and check. Sometimes they're not keeping it for everyone because, the people sometimes, I don't know why do they steal everything. In my hospital, what we were doing the skill drills every 6 months, okay? And we used to bring different things. And since once you have the dummy and and this dummy and the pelvic, this model, we used to give a lot of practice to our residents. Okay, do this for me now. Do this for me now. Okay.
okay دكتورة.
Okay, this one also, who will do this? We have many other stations, but this one also like to follow this one. I think we should do this one also. Okay, Dr. Muhammad, you can do this one, and then we will go to the other such cases like that. Take 2 minutes, and then we will talk.
Okay, you have patient in this. You have that's been taken after 39 weeks. Captain, been diagnosed with cord collapse. Diagnosed. Focus history. What you what the risk management of this patient. Toxicity of use of multicravia. طيب I would go work out شو اسمه لا إله إلا الله محمد رسول الله.
Yeah. So the first question is, does this woman have any risk factors for cord prolapse?
Yeah, I would go for I would take history if she's preterm or not, sure date or not unsure date, and
She's 39 weeks.
yeah, okay. Focus
So
history.
multiparity is a risk factor in her.
Multiparity, age, obesity, age, obesity, اسمه هذا diabetic and anencephaly, diabetic anencephaly and diabetic anencephaly, fetal abnormalities, trauma formation, fetal malformation, and history of FASAP, diagnosed FASAP before or not.
Yeah.
History of
Prolonged
bleeding,
labor, prolonged
bleeding,
labor,
prolonged
low-lying
labor,
placenta. Okay.
and
Yeah.
of brain, خلاص.
Yeah. So, and obstetric intervention is responsible for 50% of the cases like that. Remember, it's very important. Obstetric maneuvers, they are responsible for more than 50% of the cases of the cord prolapse. Okay? Polyhydramnias. Okay. So now, what will you like to ask her in the history?
طيب الهيستوري here wait history طيب اوكي what is طيب اوكي كان بلابس كان بين مع ستيبل طيب كذا طيب what's happening at home, does he feel have any history of rupture membrane or not, and rupture membrane or not, she feels something coming from down, she felt the cord, was it yeah, how what's the color of her like, or she was bleeding with it, how many times she did was it her she has she's in pain contraction, in pain and contraction, any history of her gynecology history, any history of STDs, pap smear, hepatitis B, hepatitis C, syphilis, HIV, and her vaccination history, surgical history, any surgical history, any appendectomy, any appendectomy, abdominal surgery, baby section history of adhesion, laparoscopy, and history blood transfusion, surgical family history, any history of diabetic hypertension, any congenital abnormalities, any coagulopathy in the family, or she had coagulopathy, and coagulopathy, anything. لا اله الا الله رسول الله. طيب any social history, she
Induction
is
of
married
labor.
since when, how many partners she have, how many she have,
Mm-hmm.
how many partners she have, how many kids she have. I think I pass by her obstetric history, which is how many kids she have, how many babies at home, baby section or not, or vaginal delivery or not, what type of delivery, and history of what sequel after her delivery, baby in ICU or not, and medication, medication history, she's taking any medication, any drugs, any medication, any drugs, alcoholism, smoker, and allergy, and this medication. When she and when the last time she was MBO.
So this question that obtain a focus history also tricky, okay? You will say that you will go to the ER, you will look at the patient, you will confirm her full name and age, okay? And that she is, because the identity of the patient should be there. Then I will inspect for the cord. If the cord is
Mm,
hanging outside her body, I
mm,
will announce that we have an obstetric emergency. This is cord prolapse, okay? Then the first
oh,
action would be that you will tell the sister that put this that catheterize her and put the patient in the left
Tender
lateral
back
position
position.
or in the knee
Mm,
chest position and
mm,
prepare her for the emergency section, and you will take consent from the patient that this is the after birth that this cord is lying outside and the baby can die, so we need to do the emergency section.
mm,
And you would like to ask her that you would like to observe that she has any labor pains or nothing like that, okay?
okay.
Start with the history, what was done. These dates are correct. You are 39 week. Where have you been following up? Did you break your waters? Obviously, she broke her water. That's why the cord
Mm,
is lying outside. If this is cord presentation, then remember the cord is the presenting part. Okay, and even the cord prolapse can be card prolapse can be like occult, or it can be
mm,
hidden. It can be
mm,
obvious or it can be hidden. Obvious when it has come out, and occult when it is lying by the side of the head of the baby, like that. Okay, it is one of these things. Induction of labor was done. And did she receive any? Did anyone do this amniotomy, or the membranes have ruptured her by on their own like that? Okay. Then at the same time, you will tell the sister to take the fetal heart rate through by the sonicate. Okay, because it is likely to be bradycardia. Initially, the fetal heart is present. Then you will ask her to do the to cite the CTG when we are preparing her for the OR like that. Okay. So you would like to see that how she is doing like that. Okay,
yeah.
inform the OR that we are bringing a patient for the
For section
emergency
and anesthesia,
cancer anesthesia.
anesthesia and
Yes,
consultant in
and
call, and وما تتابعوا ما مشكلة.
yeah. So now you will proceed. First, you will have a look and you will confirm that they have this prolapse cart, and then you will go like that. And then you will take consent from the patient for the emergency delivery.
Mm,
If you will say that if delivery is not imminent, they told you multi, okay? Even if he is multi,
mm,
you need to ask her that how many normal deliveries she had. Maybe this is a patient who had like multiple cesarean sections, okay? So we need
mm,
to ask her how many deliveries. And then another important thing would be ask her that you will do the when you are doing the abdominal examination, what are you looking for? You are looking for that this is vertex presentation, because
what vertex lie and
yeah,
fundal
the
height to
non
confirm the.
yeah the non-vertex presentation, that is one of the major causes of cord prolapse, like we said, in cases of breech, oblique lie, or the
oblique
breech,
lie or
oblique
breach
lecture,
present.
like
Mm,
in
mm,
all of them, the baby can have this, the mother can have this cord prolapse like that. These are the things, okay? So then you have started the CTG and you will see that the woman is dilated or not. Was any examination done or not? So you will just put one hand on the head, the presenting part, and gently I will do the VE to see that how far she is into this labor. If she is 9 centimeter and she is multi, you will give her a chance for the normal delivery, okay? Because in such circumstances you can deliver her quickly like that also, okay? You can
Mm.
start the oxygen for the mother as well so that the baby will not the this is not for the baby, this is you are oxygenating the mother, that maybe she will go for the cesarean section. That is one thing. At the
Okay,
same time, say
it.
that we
Mm.
will cover the cord with a damp, warm towel. We will avoid touching the cord because it will cause vasospasm. So blood supply to the baby would be compromised like that. Okay? Inform the OR if delivery is imminent. Okay, we will go for the delivery. And you can also apply the forceps, call the neonatologist. If even if she is 9 centimeter, we can expedite delivery by using instruments. You will use the forceps or you will use the vacuum.
In case of cord
Not
collapse,
collapse. Hmm.
she's for she's not for vaginal delivery. She's for the section.
Yeah. If she
Mm.
is multi, she is 9 centimeter, you can just apply the forceps and take the
Yeah.
baby out. Okay, that is one thing. But if
But in
she
the
is far
exam, I
from
don't think in the exam they want to save doctor. I don't think if I answer this question, I'm not. I don't know. I would go
yeah,
with the. Mm.
yeah. So go for the cesarean section, include
Mm.
the woman in decision making.
Mm.
The baby is alive, better,
The
and
normal.
delivery is not imminent. Take to the OR, do the section, and deliver.
Mm.
Okay, that is
Okay.
one thing. So you have delivered the baby, so you have done the cesarean section.
Mm.
So what will be your steps for the section?
Section first, steps for the section. I will inform the anesthesia, pediatric, the consulting core that we need to take for section. I will check her blood type and sample, blood type and blood group and CBCs and the platelet count.
Mhm.
I will keep 2 weeks back of by standby. I will start antibiotic for the patient. Cefazolin 2 gram IV and cefazolin 2 gram IV. 6 minutes prior to starting the cutting the surgery. I will take the consent for the patient, including risk of infection, risk of medicine section, including by lower segment spinal incision, Palestinian incision, with including risk of infection, bleeding, adhesion, bowel urethral injury, blood transfusion, risk of postpartum hemorrhage, and the risk of hysterectomy, and and I will especially as multiparous. I will طيب I will I will take the then I will after the consent taken I will to backer شو اسمه to for the cut to be inserted and to backer standby and oxygen intubation also anesthesia complication
Mhm.
especially which is anesthesia complication and spinal anesthesia complication just as back pain and chest pain and also in risk of DVT as well. I forgot. After that, I will go for the surgery. I will start the surgery by opening by very thin incision. After putting the patient supine position. After bringing the patient in routine manner, I would open the abdomen. After cleaning the abdomen, I will close the opening the abdomen by incision, which is 10 centimeter incision above the شو اسمه هذا about symphysis 3 centimeter incision above the symphysis and symphysis طيب
Yeah, the routine
yes
section,
yes
because here you will not face any problem in the section, okay?
yeah I will
Um,
continue open in layers the uterus will open in lower segment spinal incision in which that we open by I will open the abdomen by caudal شو اسمه I will extend the incision by caudal traction in upper and down and baby will be hope will develop baby cephalic and cephalic, and I will have repetition. I will for delayed cord clamping, and without milking the cord, I would I will take the pH sample from from it as from the cord, and I will and blood sample for the baby. And after delivering the baby, I would deliver the try to deliver the placenta simultaneously. I will ask the anesthesia to give us postpartum hemorrhage prophylaxis, such as to give misoprostol or oxytocin, and to avoid to avoid medication if she had any medication that could indicate if she has hypertension, and to clean the uterus gently, and to close the uterus and to check that there is no remaining part placenta, and to close the uterus in 2 layers. Continuous running with 1 vac continuous running suture, and will close the visceral ambulatory peritoneum in routine manner with continuous running suture with 1 vac. I will close the subcutaneous layer with 1 vac, 1 vac, 20 vac continuous running suture. I will close the skin by subcuticular suture. I will then after that I will clean the vagina after finishing massage. I will clean the vagina to check if it has any bleeder comes down there, and to check uterine clarity. After I finish that, I will do time out to confirm our procedure, and I will do time out. I will document the patient, and patient will be sent to the post-ICU community in good condition, and we will do documentation, and we will do debriefing after patient awake from the anesthesia, either in the post-ICU unit or in her room.
Yeah, well done. So important that you will put the patient in the Trendenberg or the knee chest, right?
Yeah, I forget that. That's okay.
And filling of the bladder, okay? These
Mm.
modalities to keep the pressure off the cord. Debriefing is important to tell her that such things do happen, so she doesn't have to worry excessively, and nobody could have prevented it like that. Okay? That's very good. Okay. So thank you, Dr. Muhammad. Now, Dr. Ruqayya, I think you did just one station today.
Yes.
Okay. So here is your question.
You have admitted 31 years, primary delivery.
Just one second. Today we have done the section and the thing like that. Okay.
Okay.
Okay. Go for this one. Okay. Because no need to repeat anything because you should.
Okay.
Be, yeah.
You are alive, coming to the beauty at the time of rounds and overall Mr. Jamina. Okay, doctor, I'm ready.
Okay, dear.
The step required in relation to decision. Okay, first of all, I will come to the patient, her room, introduce myself to her. I will inform her she's primi-gravid, she's 14 hour in labor, and she's on epidural. She's almost 3 hour, 2 to 3 hour at 9 cm. And for her, the baby is meconium.
Yeah.
Okay, and she has caput and molding, but okay, and for her we need to take her for emergency cesarean section. Yes, so we need to take her for emergency cesarean section because if we will let her to continue the labor at that time, we cannot go for assisted vaginal delivery because the caput and the molding and with the time will increase. And she's meconium, baby is with the meconium. And we will bring the consent. I will write the procedure name, the emergency cesarean section, and risk at that time, the infection, bleeding, and organ injury, the DVT, and the anesthesia also risk. The benefit to protect her and her baby. The alternative method, she can go for continue the normal labor with the risk for the baby and even failed assisted delivery. Then I will let her to sign. If she agree, we can go for OR. I will inform the anesthesia consultant and the pediatrician and the OR staff. We will give her the prophylactic dose, 2 gram pre-op, and we will shift her to the OR. Prepare the patient after they will give her, she's on epidural, either this with the anesthesia. Either we will continue on epidural, we will start to clean the patient, drape her, insert the Foley's catheter, and make a fenestrine incision. We will open the subcutaneous layer, then the rectus sheath, and we will open the peritoneum. Then we will go the lower transfer we will go for lower transfer segment. We will open the uterus, either a blunt or by the Caesar. We will deliver the baby. Then we'll handle to the pediatrician and clamp the cord and cut. We will take cord BH for the baby. After that, we will the anesthesia will give her the syntocinon, and we will deliver the placenta. I will deliver the placenta. Then we will secure the angle. We will suture the uterus by 2 layers, and then we will secure the hemostasis. We will check the ovary and the tube in the both sides, and we will clean the blood in the peritoneum area. Then we will close the layer. After we will close, it depends either the peritoneum we will close or no, that's different.
Peritoneum, don't close peritoneum because mother will have fever. So no need to close peritoneum, okay?
Yeah, I thought this is different. It's controversial about the guideline. But yes, then we will close the rectus sheath and the subcutaneous fluid if more than 2 cm. We will close the suture, the skin, subcuticular. In case if we have bleeding, we can put the drain. Otherwise, we will not put. Then we will cover the wound. We will clean the vagina. The uterus will see the amount of the bleeding, and after that we will write for her the post-operative note and the amount of the blood loss and at that time, yes, the instruments and the count, everything complete. And the post-op order, we will keep the patient in BO for 6 to 8 hours. Then we will give her the Clexane 8 hour postpartum, and we will continue for her the IV fluid with the Cinto for 4 hours, and we will give her the good analgesia. Either we will give her good analgesia, the opioid with the antiemetic, and we'll give her also the Berfergan 1 gram Q6 hour. And if she don't have any allergy, we can give her also the Voltaren, non-steroidal, and we will observe her vital signs, and we will check the amount of the bleeding and the dressing also. We will repeat for her the CBC 20 to 48 hour post cesarean, and we will remove the catheter 8 hour if urine output is good, and yes,
Yeah,
and we will check her
things.
blood group. If she's Rh negative, we will give her anti-D, and her rubella status. If not immune, we will give her MMR vaccine, and then we will inform the patient, debrief after full documentation. We will debrief for the patient the situation the next day during the round.
Yeah, debrief the patient, clinical governance, okay? The same points like we mentioned before. So you will have to apply here also. This one also like because of the obstructed labor like that, okay? The previous one we did. Here, you have a few things like 1/5 head palpable and there is capet and molding, okay? So you can say a couple of things about molding that you will try to separate swipe your finger along the head of the baby. If the bones can be separated, it means that mild overlapping. If the bones cannot be separated, then it means severe molding like that. Okay. The caput is there and plan for the future pregnancies. Book with a consultant. 1 in 4 chance that she will need another cesarean section like that. Okay. That is one thing.
Mm.
Schedule
Yeah,
post
this
appointment.
according. We will tell her يعني,
Yeah. And tell her
case
about the
of
breastfeeding. Mm-hmm.
yeah, for the breastfeeding. They're supposed to start breastfeeding, and if she's also general anesthesia for what we call it, spirometry, and early ambulation.
Mm-hmm.
Um,
Incentive spirometry, okay? That is a type of
yes.
physiotherapy, yeah.
Uh, okay, that
Yeah, these are
and
the things in the
this is
post-op care,
yes. And
ambulation, healthy
postpartum,
diet.
for her, she will breastfeeding, and we will give her appointment to counsel her about the contraceptive. And at time, we'll inform her the next delivery she can go for the trial of labor or supposed to go for elective cesarean.
Yeah.
Because in case if we have extension or like classical cesarean T inversion, that time we'll tell her about the elective cesarean or CBD.
Okay. Thank you. They can also ask you to tell about the intrapartum sections, the same thing, okay? But they want you to have the good explanation that what steps you will do and what precautions you will take. They're always asking that question, okay? So this one
طيب.
also for you, and then I will see that if Fatma is there, then she will do one, and Dr. Muhammad will do one. So this one is your third case.
طب دكتورة, for like this, that's the previous question. I suppose because I mentioned just single dose, that one only in the second stage, صح?
Yeah, this is
You
also the
said we will
second
give her the more
because
extra dose.
yeah, this is tricky. What is in the third stage of the labor? Placenta, right?
Mm.
So you have already delivered the baby. So the baby is still there, and she is contracting. So she is still she is fully dilated. Okay, so that is the second stage cesarean section. From effective contractions to full dilatation, first stage. Full dilatation to delivery of the baby, second stage. Okay,
Yeah,
and
okay.
then from the delivery of the baby to the delivery of the placenta, third stage, like that. Okay, so this is also a second stage section. These are different ways of asking the Same question.
Okay.
Okay, that is one thing. The
You see
issue
the
here is,
scenario? Yeah.
yeah, issue here is that there are like many um, the things are very simple. You are doing them every day in the practice, but what happens under the stress of exam, people they forget to mention it. Okay, that is why we need to do such stations. So let me take you to this question. Okay. So tell me, what is an episiotomy? So you can say this is an operation on the perineum performed to enlarge the birth outlet to facilitate the delivery of the fetus. That is one thing, okay? So what tissues are cut here? So what do we cut in the episiotomy?
Is perineal muscle?
Bulbospongiosis muscle, okay? Superficial transverse perineal muscles, like bulbospongiosis, like that, okay? So this is, you can also define it as a second degree intentional injury tear, intentional cut into the perineum to facilitate the birth of the baby, like that. Okay. So where it should be taken? What should be the exact location?
Okay, the precaution you can take to prevent avoid. Um, at the time of the crowning, after giving the patient local analgesia,
Mm-hmm.
we will cut right mediolateral or
Mm-hmm.
midline.
Okay. So how do you compare both? Which one is better?
So for the midline, is more uh, uh, midline is less pain and less pain and less bleeding, but more for extension to the third and fourth degree perineal tear. For mediolateral, is more pain. The bleeding is more, but is more safer for the second and third degree tear. Um,
Yeah, less dyspareunia in the um, uh, midline and more dyspareunia in the lateral one. Just mention these 3 points, they are more than enough, like that. So, what are the indications for episiotomy? Here you should say that it should be selective, okay? It should not be for
yes,
everyone, it should be selective, like only where it
but
is going to give you
yeah, and usually not
restrictive,
for the
okay?
widening, for the
So, yeah,
يعني not for the widening for the delivery of the baby, for like instrumental delivery or for manipulation.
yeah.
And
For
it depends if she has short perineum and in select case. And sounds depend on
restrictive.
the policy even.
I'm so restrictive means what you are telling me that only if indicated then we should do it. Selective means that we have thought that we will do it on all primary gravidas. Actually, this is not required because maybe the primary is passing a small baby. So why do you want to cut her like that? Okay, and that is one thing. And when you tell about the right mediolateral, it should be 45 to 60 degree away from the midline. That is one thing. And it should be 5 centimeters long, 2.5 to 5 centimeter long. That is the size, like that. Okay. So, right. So when you will consider this episiotomy, you have just told me like that, okay? Under which conditions you will like to do this episiotomy? When you want to expedite delivery or you want to do the operative vaginal delivery like that, okay? So that you are in cases of shoulder dystocia where you want to do the internal maneuvers like that, okay? So that is one thing, okay? So will you tell me about the procedure, the steps that how you will start it and how you will repair it?
Okay. After we put the patient in the lithotomy position and clean her, prepare her for the delivery with a good light. At the time of crowning, we will give her, or before, in between, before the crowning, we give her the local analgesia with lidocaine. And at time of crowning, we will we will make the cutting. Um, yes, and during the delivery, we will make the support to not make even for the right midulateral the extension. After delivery the baby and deliver the placenta, um, we will check the edge of the placenta if we have extension inside, if we have third or fourth degree tear. In case of third or fourth degree tear, we will call or we need to put the patient in the OR. But in case if we don't have complication, we will from the apex, we will by the ficral 20 is non-cutting needle. We will go behind around 1/2 to 1 cm.
Mm-hmm.
We will take the apex. Then we will approximate the edge. Uh, then we will take, if we have like dead space, we will take another separate suturing. We will close the muscle together, and either we do it continuous or till they reach um, the hymen. We will take the interrupted. We will suture also the muscle, and then we will make subcuticular or interrupted mattress suturing. And we will we will be sure no I don't have gap and no hematoma, and we will do BR to check I don't have any suturing in the anal canal, and we'll give her analgesia, good analgesia, and we will give her the laxative. We will encourage the patient about the perineal care to avoid the infection. We'll inform her the suture will fall down alone. That's it. In
Okay.
case if we have extension, at that time just we will give her antibiotic. Otherwise, no need for antibiotic.
Yeah, antibiotics neat and clean case, you don't need that. You didn't take consent from the patient, okay? Take the consent and tell her that how it will, why it is necessary, what will happen
Verbal
like that,
consent,
okay?
صح?
And yeah, and verbal consent, and then you will say that I will see that the perineum has been numbed. If not so, then I will give 5 to 20 ml of the 1% lidocaine solution, okay? Where you will give start at the fourchette and you will advance into the vaginal wall like that, okay? That
Okay.
is one thing. And the muscles that you are going to cut, superficial transverse perineal muscles. Basically, pubococcygeus muscle is the one that we are cutting. Remember the name of the muscle. Pubococcygeus,
This is muscle.
yeah, pubococcygeus muscle. That is part of the levator ani. That is one thing. Okay. So, and you should know about the things that how after delivery of the baby, what you will do. You will inspect the whole area like that, okay? You will look for any additional lacerations, anything, any surface that is bleeding like that, okay? Then I agree with you. that the anesthesia is there, and we are going to start at the tip of the foci or at the tip of the episiotomy, or which is like the inverted V shape, like that. That is one thing. So rest of it, yes, I agree with you. Okay. So once you have sutured everything, then what will you like to do? And you are using Vicryl rapid for the skin and the for the vaginal mucosa. You can use anything, but better to use the Vicryl rapid. For the muscles, what will you like to use? Again, you can use the Vicryl. Okay, don't use the thicker one. You can use the thinner one. And for the perineal skin also, you will use the Vicryl rapid like that. Polygalactin, polydioxin, both can be used like that. Okay, that is one thing. So you have completed the episiotomy. After that, see that the counts and the needles are complete. Okay, so nothing is left
Oh,
inside vagina. Change your glove, or with the same glove, just wipe your little finger. Take consent from the patient and do the PR. So to exclude that there is any stitch into the into the rectum, because if it is so, then you will have to
remove it.
cut that stitch. That is one thing. Okay. And then you can give the patient Indosit suppository rectally at the same time, because it will prevent this pain requirement for larger quantity of the painkillers, and also it will decrease the inflammation like that. That is the thing. Okay. Tell her about the episiotomy, that she doesn't have to take antibiotics, doesn't have to apply anything on the external surface, just keep the area dry like that. Okay. Maintain perineal hygiene. If he wants to touch her perineum, first she should wash her hands, and then examine, then touch the area. Because sometimes the people, they have flu, common colds, and they will use the same hand to wash the area, and then these areas, they can become infected like that. Okay, that's all you need to tell her. No need for the stool towel softener, but she should be taking adequate amount of the bulk or the bar in her food to avoid constipation like that. Tell her that the stitches, they will be dissolved on their own, so no need to go to the hospital for their removal. Important things. Okay. And if so, that patient should know that these stitches will come out once the skin has healed, because the poor girls, once the stitches would start coming out, they become excessively worried that maybe they have broken down their episiotomy. Like, that is one thing. Okay. If she will have any pain, anything, she will be given only simple anesthesia like paracetamol. It is going to heal on its own within like 2-3 weeks, so she doesn't have to do anything specially for it like that. That is one thing. If they give you somebody with the breakdown of the episiotomy, so what will you do for that?
Breakdown is depend.
Mm-hmm.
Either the tissue is infected, we will give her
Mm-hmm.
the antibiotic, and
Okay.
we will counsel her. Either
Mm-hmm.
I will give her, I will start with her antibiotic, either it's healed spontaneous with the time, or we can go for the bride and suture it.
Yeah.
I will include the patient in the decision making,
Yeah.
because most of them they prefer to close it early.
So you will tell them, once you have the patient, the counseling would be important. Okay, I will inspect the area. I will look for any signs of infections or any sign of discharge or bleeding. If there is no bleeding and there is no discharge, there is no foul smelling discharge, we don't have to do anything. Just clean the area with the normal saline, reassure the patient, and we can give her a painkiller. And if there is like smelly discharge, you can give her antibiotic. If the smelly discharge is not there and there is no bleeding, no necrotic issue, you don't have to do anything. So you will tell her that the area is closing and give yourself 2 weeks. It is going to heal on its own. Second way out can be like there will be spontaneous closure, and usually the breakdown is occurring at the day 8, and it is usually the superficial. Unless there is hematoma, the patient is running fever, and patient has throbbing pain, and the area is swollen, tender, you don't have to do anything. If it is And what you can tell her, that she is feeling the discomfort, tell her about the sitz bath, that she should take tolerable lukewarm water and sit in that for 3 4 times a day, like that. Every time she should be sitting for like 5 to 10 minutes. That is one thing. Okay, that will be because of the cellulitis, no infection. Second outcome can be that the patient has a broken wound and there is exudate and necrotic tissue. If there is exudate, there is necrotic tissue, then you have to take out these things, remove the suture fragments, and then cover this patient with the antibiotics, wash it with the normal saline, and give her time. Okay, we'll do it like for 2 3 days, and then under local anesthesia, you will have to refresh the edges, remove the tissues, and then you are going to suture that. Most of the patients, sometimes, if it is not like there is not necrotic tissue, then you don't have to do anything. Clean the area, remove any dead tissue if you can find, and then remove any slight suture material that you find, and let the patient have these sits pass. She's going to be fine. Now the third one, the patient will have severe pain, very bad discharge, and widely opened thing, and there is no granulation tissue. This is all inflamed. Okay, so in that, what you will do, in that you will give her antibiotics, you will give her the painkiller, better to give cephalosporins, and then after that, what can we do, we can refresh the edges, and then we can close it, and this time you will give her second generation cephalosporins, and you can give or you can give them first generation cephalosporin like the
Cefalozin.
cephalosporin with metronidazole, like that. Tell them about the hygiene and tell them about the sits pass, like that. Okay? So she's going to be fine, and review her later after 4 5 weeks, like that. That is it. Okay? That's all you need to do for her.
And
Episiotomy,
after
people.
that, I will suture it or not?
No, no. I said that if it is widely open, yes, you will suture that.
Yeah.
Widely open, like the gap is more than 2 centimeter partition. Give antibiotics, refresh the edges under local anesthesia, suture it. And now give her double antibiotics, cefazoline and metronidazole, or give her second generation cephalosporin. Uh, Care, and then she can go home. Three outcomes, okay? First
Okay.
one, nothing, reassurance, send her home. Give her the painkiller, tell her about the SIDS pass. Second one, keep her inside hospital for observation if the gap is less than like 2 centimeter and there is no exudate, no thick pus, even light discharge is there, don't worry. Just send the swab for culture. Wash the area every single day with normal saline and give her the painkillers and tell her about the SIDS bath. SIDS bath 4 to 5 times in the inside hospital. She starts signs of improvement, give her painkillers, she will go home. The third variety, where it is septic already and she has wide gap and she has poor discharge, very smelly discharge from here, or she has fever or she is having spikes of fever and she has extremely tender area. Remember, group A beta hemolytic streptococci can also cause this problem. Okay, so you have to be careful about it. In that case, again, we will watch the area. We will give her antibiotic for like 24 hours. After 24 hours, under local anesthesia, even in the this daycare theater, under local anesthesia, refresh the edges, restore anatomy, and give her second generation antibiotic cephalosporin or cefazolin, which is first generation with metronidazole. Give her this treatment for 5 days. Tell her about maintaining the perineal hygiene and what you have to do, and sits baths. Okay, sits bath in to all the patients, like that. And she should avoid constipation, and if the condition persists, then she should return to the hospital. Usually nothing will happen beyond this point, but if it occurs, then you can do that. And you have taken the swab, so you will do the culture sensitivity if you need to change the antibiotics. That's all you need to do for her.
Okay.
So repairing the fourth degree perineal tear is also not a big issue. So first I was going to give you the station, but I think no need. Just remember that how you, again, you will do the inspection. Okay. You have done the inspection. You will see that how bad is the thing. Classify it to the higher grade. There will be loss of puckering around the anus. Inform the anesthetist. Take this patient to the OR, and you are going to see the different areas like that. Okay. This is the simple one. This is the anal epithelium. Okay. If the anal epithelium has been breached, let me enlarge this one for you if I can. This is anal epithelium, breached already fourth degree. Okay. This is the internal inner sphincter. It will be running longitudinally. External inner sphincter you can see, and inner sphincter you can see it is running in the circular way like that. Okay, that is one thing. The darker one will be the external anal sphincter. Identify the anatomy, take the patient to the OR. The person who is doing it should have good experience, and they should do end-to-end anastomosis, and they should cover them with restore anatomy, see that the counts are complete, she has no other problems, and she will receive the antibiotics. Okay. And what we will give her, if there is first or like for the episiotomy, if you want to suture, you will give first generation cephalosporin. But if you have a patient with the second or this third or fourth degree tear, then you will have to give her double antibiotics like metronidazole, and second generation cephalosporin should be given. And if they are allergic to cephalosporins, what will you give them? You will give them beta-lactam
Like that.
antibiotics like that, after excluding the allergies like that. Okay. So the third and the fourth degree tear, again, you will have to repair them under good light by the expert, under general anesthesia, so that she will be relaxing. The sutures are the same, and anything you will do, you need to tell them why you will do that. So why you will do the repair the third and or the fourth degree tear? Because you want to restore the normal muscular layer and the skin like that, and to retain the function of the anal canal and the sphincter. That's why we are fixing it like that. So what you will do, you will repair the torn anal mucosa first of all with a running or continuous non-locking suture, which can be polygalactin 30 or 40. In the gynae, we are mostly using 30, but if the patient is super sensitive, you can use the 40 as well. Okay, that is one thing. We will use it, and then after repairing the mucosa, you will
And
close
the
that.
note, doctora, in the mucosa.
Yeah, anal mucosa, then the internal anal sphincter, you will repair that one. It can be
Yeah,
repaired
yeah.
with,
I mean the note, the surgical note.
yeah, the knot. I think we discussed before also. The you can put the surgical knot, and but you will bury that under the surface, under the
Okay.
epithelium, or under the mucosa. Mucosa is outside the muscle. Why? So that there will be no migration of the knot. Running fashion, so that there is no tension on the anal mucosal wall. Then suture the internal anal sphincter with polydiaxanon or polygalactin 20. Okay. Then go to the external anal sphincter, that can also be repaired with the same suture, or you can use the 30 is better for using. Okay, both polydiaxanon and polygalactin. So polygalactin is your regular Vicryl. So you have done that one. You can say that we can adopt both any of the two techniques like end-to-end or figure of eight. End-to-end is preferred because it will not compromise the blood flow. That is one thing. Okay. So you can take the continuous sutures or interrupted. If you are putting the interrupted sutures, usually 4 to 5 sutures are taken, and you are going to be fine. And then in the end, you will go towards the vaginal mucosa. Close that. There are the muscles. Clear them, and then in the end, with the Vicryl rapid, you are going to close the skin. If there is any other isolated injury in the rectum, you will say that this is buttonhole injury, and you are going to take note of that, and you will repair it separately like that. Okay. The complications, your patient can have perineal pain, dyspareunia, which may last for 3 to 6 months, but 100% patients they will be fine after 6 months, within 1 year. 60 to 80% patients they will have no complaints at all. So you have repaired the fourth degree perineal tear. What precautions you will tell your patient to take?
Avoid the constipation, about the hygiene, and counseling for the next delivery.
Yeah, you should say that the fourth degree perineal tears they are associated with higher chance of perineal floor dysfunction, which includes urinary incontinence and the prolapse. So you will tell the patient that once the pain has subsided, she should do pelvic floor physiotherapy. Okay, that is one thing. Once the pain is away, then he should do that one. And we should tell her that she can have pain, she can have dyspareunia, so we will give her the treatment for it, like the painkillers, or she can use the lidocaine gel when she's having this dyspareunia. These are the things that you need to write, debriefing, and tell her that the chance of having another sphincter laceration in the next pregnancy is less than 1.7%, like that, less than 2%. That is the point, okay? And she should come back after 6 weeks, like that. That is one thing. So let's say that she has returned to you after 6 weeks, and she's complaining of that she's losing the stool, she cannot hold on to her winds and waters properly. What will you do now?
I will examine her to check if she has fistula or no.
Mm-hmm.
Um, After examination, I will do for her the Kegel exercise and pelvic floor physiotherapy. I will refer her to Gynae.
Yeah, do everything, continue the same things, same treatment for another 6 weeks. After 12 weeks, she has the same problems. You will do anal manometry if the anal pressure, or you will do that endo-anal ultrasound and anal manometry. On ultrasound, you can see any defect or the pressure is less than like 10 millimeters of mercury, then you will refer to the colorectal surgeon for the further management. That is
If
your
more than,
more pressure is less than 10 millimeters of mercury, because the patient cannot maintain the pressure, okay, like that. So then you will have to send her to the colorectal surgeon. If at the end of 12-week period she has urinary incontinence, send her to the urogynecology and document everything in her notes, like that. Okay, dears, is Dr. Fatma there?
no. Doctora, what about the anal ultrasound? If I will do it, if normal, she has chance to go for normal delivery.
Yeah, yeah.
No, elective cesarean. I know it's controversial, but if
At
you
one
have
year.
normal,
1 year.
after 1 year, after you
Yeah.
have normal ultrasound, better to go elective cesarean. But if she has still defect, this her choice, either elective or she
Yeah.
will go for normal.
Yes. Yes, she can go for normal, and it will be associated with a slight increase in her problems. But then after delivery of this baby, we can fix the things in a better way. If she is
Uh,
like symptomatic at 1 year of age, like that, okay. But usually, if your patient is symptomatic at 1 year, this is the indication to send her to the colorectal and do the needful, like that. These things are important.
okay, thank you.
Welcome. Okay, Dr. Muhannad, are you there?
Yes, I'm here.
Okay, doctor. This is the one for you.
Okay. This patient is 34 years old, para 5, bleeding, heavy bleeding, postpartum hemorrhage, or what? Placenta is still undeveloped. How will you manage this patient postpartum hemorrhage manually and manually with the placenta? طيب. First, I just was called for the patient. I just came to see the patient. As the patient is bleeding, شو اسمه هذا as the patient is bleeding, I will ask for help. I will inform the anesthesia. about the case, the consulting call. I will ask for 2 unit pack RBCs to be standby and to stand by, and I will go for to insert 2 unit pack to IV line and large pool, and secure airway breathing and circulation, and give her bolus fluid. I would go after that to شو اسمه هذا to ensure the way vital is stable or not. I would go to examining the patient. How is the how is the patient looking? Is the patient pallor? How is the vitals? Patient tachycardic or not? I would examine the patient. I would see how is he bleeding now. She's heavy bleeding. She's heavily bleeding. شو اسمه هذا heavy bleeding due to return placenta, and I will check the abdomen if uterus will contracted or not. I will follow. I will ask for I will ask for misoprostol. or ask for شو اسمه هذا I will ask for oxytocin and 50 milligram 15 unit intramuscular, or 5 unit running IV. I'll ask for tissue. I will ask for misoprostol as well. 8 milligram to be given. I will give it 800 mcg rectally, and I will I will examine the patient to see what's the cause of bleeding, and if the placenta is still there, and we cannot remove we cannot deliver the placenta, I will proceed for removal of placenta, and under general anesthesia, and for the anesthesia about the case, I will quickly consider the patient when manner removal placenta under anesthesia, under general anesthesia, plus minus laparotomy, plus minus tubal ligation, plus minus pachycerebral balloon insertion, plus minus hysterectomy with hysterectomy, and with the risk of infection and bleeding, and injury to adjuvant organ, and injured bladder or neurological injury, and with the NC. And طيب I will proceed to I will following that I will proceed to manual removal. I will sorry I will the patient still I will take brief history before that, quick history from the attendant. What's happened? She's multivirus or not? Placenta, where's placenta location? Was confirmed by sound placenta preview history placenta then sexual or not? Placenta location, delivery was simultaneous or induction of labor, heredity, any medical history of diabetic hypertension, and history of coagulopathy before, what's his RH type, and surgical history of cesarean section, any uterine, any history of DNC or metaplasty, or histoscopy or histoscopy. طيب after that I would go for بس والله I would go for my operation. I would do manual removal under anesthesia, and with that I will try to hold I will put the patient I will put the patient in lethal position, and in lethal position I will put my hand I will put my hand first in the abdomen to just push the uterus for me. Then I will insert my hand in I will do by manual examination, but I will insert my hand inside the uterus to try to hook the placenta. In which that I will try to separate the placenta from the placenta from the uterus by going to placental bed. Until that I can take it as, I'm sure I will take it as a whole. Once I take it as a whole and I remove it as I separate all the placenta, I was sure of it. I will try to hook the placenta. I will take it. I will pull it gently, as it's come with me. After just to make sure, I will check that after that if she has any bleeding or not. If she has bleeding, I will do بس I will just do if the bleeding stopped, most likely placenta went away. I will confirm by بس scan if any part of placenta was there. If there is still part of placenta but not bleeding, I will try to remove it either by manually or by DNC. And if there is part of it I cannot remove it manually, I will just I will ask for the DNC DNC sit as I put in the consent, in which that I will hold the cervix. I will put the speculum that I will hold the cervix, and I will hold the cervix by tenaculum. As the uterus will open, I will take forceps if I can receive the kind of and I will try to move the RBOCs under ultrasound by the forceps, and I will do just simple gentle curettage to check that to ensure that there's no other RBOCs if she has still bleeding. And after the fish is finished, I will if there's no bleeding, I will check before finishing. I will check if there's bleeding was contracted or not. I will ask him to give us contracting agents as oxytocin, misoprostol, or to repeat to give us hemabate and hemabate and I forgot to give him hemabate and to see when there's some she received the hemabate and the doses. And this is it. خلاص I will finish procedure. I will do time out. I will after that I will debrief the patient what's happened to her, and خلاص this is it for me.
Yes, that is
I
the thing.
forgot to
Yeah.
mention the medication اللي هي الهيمابيت and the other one اللي بدها potential عارف توصف ليه.
If you mention the overall management, Himabate is very good. These are the things, but my advice would be that start with the simplest things like that. Okay. Quantify, try to estimate that how much is the blood loss like that. Okay. Then when you are sending the blood, you should say that you will send the blood for CBC, and if he is having like a major hemorrhage, then you will have to do the coagulation screen as well. Say very clearly that the patient has PPH. Okay. And then tell her that you have ongoing bleeding, so we need to manage it. So you will be doing different things. You will be doing the investigation of the patient. You will be treating the patient. You will be monitoring the condition. Then communication is very important. Ask somebody to stand on a side and write down everything that we are doing, who came and what was their role. Okay, how much fluid we have given. You have started with the oxygen. You have given her the IV lines. You have started the crystalloids, the colloids, and then you have given the tonics. Okay, the aim is to stop the bleeding and keep your patient safe like that. Start with the simplest thing, okay? Like you will first quantify that how much blood loss is there. Obtain assistance, that is the most important thing. Call for help like that. Okay? You will call for the help? Make everyone alert. Call the obstetrician, anesthetist, the hematologist, the blood bank. Ask for additional nursing staff because this one is occurring after delivery, so she is here like that. Okay, that is one thing. Alert the surgery that in case we need vascular surgeon later. Monitor signs spontaneously, all vital signs, and the urine output, and how much is the blood loss like that. Okay. So the patient should be lying in the bed. People are around her. People who are not involved in the care of the patient, ask them to leave the room to make some place. Okay. 20 cc blood we are taking, and we are putting the catheter or they call it phlebotomy, but you will say that you will put the IV cannula size 14 or 16, which one is available. First step, oxygen. IV lines, crystallites, and then the colloids till we can give them 3.5 liters, and we are trying to maintain urine output above 30 units. Then get the cross-match blood. If the cross-match blood is not available, check patient's acceptance for the blood or the blood products. You can give the O negative blood. Say that enough anesthesia is available for the
digital exploration of the vagina. That is one thing. And then what we can do, you also have to do the abdominal examination, vaginal and the rectal. Sorry, to see the extent of the bleeding like that. So after that, like you will give the uterotonics rapidly, you will give it to them. You can give them the start with the oxytocin 10 units intramuscular, okay? That is one thing. Because the point is that you give IV or you give IM, the action is going to start at the same time. So after that, you can give them centrometrine. Nothing is happening, go for the carboprost. Nothing is happening if there is no contraindication. Carboprost, you have given 8 doses. You can add tranexamicin, hemabate,
Mm.
and you have like, and if your patient is bleeding, then you can do is that assess the need for the blood therapy. Blood transfusion can be started like that. So basically, in most of the cases, the cause is tone of the uterus. So you are going to manage the 8 and E. So you have given the syntocinon, but you will also like to continue the continuous infusion like that. Okay, mention
That's
that.
good. Mm.
If
Mm.
there are any laceration, you will fix them. If the placenta is still attached, you will look for the placenta accreta and you will take the patient to the OR like that. Okay. If only the genital lacerations are there, then you're going to fix them yourself like that. And you should be able to hold the suture in the point of the apex. So sometimes the patient would be bleeding only from the apex like that. So these methods you have done, you have come this far, no effect, nothing. Then we need to take the patient to the OR like that. Okay? So inside OR, like obviously we are going to look for the other things. Regarding the eucrotonics, you have given oxytocin, you have given symptometrin, nothing is happening. You have given carboprost, no effect. After carboprost, you have the option to give her misoprostol, which is prostaglandin E1. After that, you can give them methyl ergoneven. The contraindications would be like for any methadone, cardiac disease, PET, hypertension, like that. We are allergic to the drug substances like that. After that, you should go for this. You try tamponade that will be inside OR like that. Okay, we will try to put the battery balloon and we will inflate it with 300 to 400 normal saline. If it is useful, then we are going to keep it there. If it is not helpful, then we will have to think about the other options like that. Okay. Sometimes what they do that if balloon is not working, then sometimes they like to pack the uterus also and then observe her. If still she has bleeding, now this is the thing that you are going to. You will have to open the patient. You will go for the stepwise devascularization and nothing is happening. Stepwise devascularization, like you're going to close the uterine, no effect on bleeding, you will close the ovarian. Still patient is bleeding, then you are going to close the aorta. What about the brace sutures? Tamponade is failing, go for the brace sutures. That is a good option. Take the stitches, you will use Viclar 1 or 2, and you will take the first suture 2 3 centimeter away from the lateral wall of the uterus. Take suture,
Mm.
go upward to the fundus, come back, and then again go around the uterus and come out 3 centimeter medial to the other side of the uterus, wall of the uterus. Tie them and observe the patient. If she improves, okay, well and good. If she doesn't, then this is the time that you will go for the stepwise devascularization. You can block the internal iliac anterior division of the internal iliac, not the posterior one. Just close the anterior one. Still she is bleeding, then you will have to go for you can do the aortic compression, and if the patient improves a little bit, okay, we will see that the patient has improved like that. Okay, because the point is that even if she stops to bleed for some time, the hemostatic clots will form and the uterotonics, they will have their effect and the uterus will close. Usually this intervention is also helpful. If not, then within 30 minutes you have to call the second clinician and you have to decide for the peripartum cesarean, peripartum hysterectomy like that. These are the things, okay? So there are certain prerequisites that what should be the standard level of the hemoglobin should be kept over more than 8 grams per deciliter, okay? And the fibrinogen level should be more than 2, okay? And once you have given the misoprostol, tranexamic acid, ergonomine, everything, then you can also give them the fresh frozen plasma if they have oozing from the surfaces, and you can give them cryoprecipitate. If nothing else is working, you can give them factor 7 as well. Okay, so these are the things. Packed RBCs can be given. You will follow the protocol for the massive blood transfusion, and if the patient develops like electrolyte abnormalities, then you are going to fix them. That's all you need to tell them. You are going to keep a record of everything. You need to debrief your patient, and you need to do the risk management by running the skill drills inside hospital. Everybody should know that management of the PPH is very important, because if we fail to do that, we can lose our patient. Okay, these things are very, very important. I would suggest go over the obstetric emergencies if you have time today. Okay, doctors. Anything else?
Yes, Doctor. Regarding you said always check the شو اسمه the note in the شو اسمه what call it in the website. Actually, because the website it is we need to go down. Sometimes it's hanging with us while we are looking for the same for one document. For example, I was trying to look for the one you told me about
Mm-hmm.
لا إله إلا الله محمد رسول الله just now. Um,
What for?
the one you told me about, the one for pushing technique and these techniques.
Yeah, yeah.
I tried to look for it, but the issue that it is sometimes hanging on me because it is a document like 30 papers. I need
I will tell.
sometimes a lot of time is hanging on us. We cannot even go down there to the last paper. This is our issue. Is that an issue? Is we can find it. It will take time for us to find this document. This is the issue. The one you talk about.
Okay, I will tell you. Yeah.
Mm.
Go to the obstetric surgery. Let me see that it is still by the name like that. Okay. Go to the obstetric surgery. You will find all of these things. The uterine inversion, breech, card prolapse, and no, the
We, we,
procedures. You will
we
find
can
every.
find
Let
we
me
find
see.
in history. We find it in search.
Yeah, in the obstetric surgery, you will find all the surgical steps like that. Okay.
Okay, طيب خلاص.
In the obstetric emergencies, you should be able to find the PPH. You should be able to find the card prolapse, shoulder dystocia, breech presentation, okay, third and fourth degree perineal tears like that. Let me see that. What is the status? Actually, right now, 4 courses are running, like different people for different duration and everything. What is your passport? Because I need to see your passport so that I can enter this one. Okay, OPT 22. You know, when you will go to the end of the page like that, maybe there is another page for you guys as well. From there, you can go to the page 2 like that, okay? Like that. Similarly, you can from the bottom of the page, you can go to the other pages as well.
This is the technique that we were doing, like pushing the uterus up and then keeping it there like that. So like this, you should be able to find your notes, that where are they, like those on the PPA, on the obstetric emergencies, exact page, that on which page they lie. Because today here also the internet is not behaving that well, like, so you will have to spend some time, but you will find the all the stations, the all the OSCE thing, that everything we are doing here, only the stations are different like that, okay? But the underlying things, like in the obstetric surgery, maybe you will find many things. It shows here. Today our internet is not very good. That's why these notes are not appearing. But you can say that, see that there are 36 pages for the obstetric surgery like that. Okay. See what will you discuss with the patient, these things, and you will go to the next pages, and you should be able to find like that the two poles of cryoprecipitate, and then even after the PPS, you need to give them where you will keep them in the HDU. You need to give them VDE prophylaxis, dead stockings, everything like that. Okay, these are the things. You still have some time. I'm sure that you are like well prepared. You are working very well on the exam. But if you find time, you can go here also like that. Okay, these are the things. So just try. Still, any problem, not found anything, then please let me know. Then I will see that what can I do about it. Okay. Anything else?
No, thank you, Doctor. We are okay. Thank you very much.
Okay, dear. Take care. Then see you, inshallah. Bye bye.
هذا في هنا، ايوه شفتها.